Ladies and gentlemen, the opening ceremony is going to start in 5 minutes. Please be prepared.
Ladies and gentlemen, before we begin the ceremony, here's Hiramia Dance performed by Sisianti Musanif, Sri Utami Tahir, Alia Aprilia Ibrahim, and Mardatila Polamolo. Hiramea is a dance that is demonstrated when welcoming a happy day in rice harvesting, showcases the festivity of young people and cooperation. Hiramea literally means together, which interpreted as a hope of the youth that keep moving forward to build nation. Please welcome Hiramea Dance from Nursing Department.
Give big applause for the dancer of Hiramia Cultural Dance. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon us. Om Swastiastu, Shalom.
Namo Buddhaya and salam kebajikan.
Distinguished guest participants, ladies and gentlemen, it is an honor for us to introduce the welcome guest today. For the first one is Director General of Health Workers, Dr. Gigi Arianti Anaya MKM. Director of Gorontalo Health Polytechnic, Muhammad Anas Anasiru SKM MKes. Head of Nursing Departments of Gorontalo Health Polytechnic Ratawati SKep Nurse MKep. Professor Sudaf SP Warnakula Surya PhD from Colombo University, Sri Lanka.
Dr. Lee Wan Ling from University of Malaya, Malaysia. Professor Sing Mei Chen PhD from National Cheng Kung, Taiwan. Dr. Debbie Dahlia SKP MHSM Universitas Indonesia. Andi Masyita Irwan SKep Nurse Man PhD Universitas Hasanuddin Indonesia. All the supporting partners and presenters and participants. Good morning and welcome the first International Conference on Nursing Update and Healthcare 2023
with the themes Health Transformation and Management of Degenerative Disease. The main objective of this conference is to serve as a forum of exchanging ideas on health transformation update related to degenerative disease.
Distinguished guests, participants, ladies and gentlemen, we would like to start this session by inviting everyone to stand up for the national anthem of Indonesia. Please remain standing for Mars Indonesia National Nurses Association.
Persatuan Perawat Nasional Indonesia, wujud ikatan profesi perawatan, tempat membina dan mengembangkan kemampuan diri dalam membuktikan keberadaannya. Menapaklah dengan keyakinan lebih pasti, sejajar dalam abdikan diri, bangkit berdiri dan langkahkan kakimu itu, menatap hari esok penuh asa. Wahai perawat Indonesia bangkitlah dan majulah untuk menolong sekalian yang menderita. Kuatkanlah pribadimu, tingkatkan pengetahuan untuk memberikan asuhan keperawatan. Kita melangkah untuk mengisi pembangunan bangsa negara Indonesia, untuk menghantarkan bangsa menuju sehat semua dengan semangat jiwa Pancasila. Maju perawat, majulah dalam kancah pembangunan, tunjukkanlah pada sekalian orang. Jadilah perawat model kesehatan bangsa kita, jadilah teladan dalam hidup sehat. Bangkitlah perawat seluruh Indonesia dalam mengemban citra profesi, menjunjung tinggi kode etik keperawatan, laksanakan panggilan tugas mulia, mencapai derajat kesehatan seoptimal mungkin bagi warga negara Indonesia. Sebagai bukti kiprahnya mahkota putih suci dalam mendukung pembangunan kesehatan. Dengan organisasi PPNI yang kokoh, padu bersatu serta selaras, perawat Indonesia akan mampu angkat citranya di mata insan dunia.
Participants, ladies and gentlemen, please be seated. Thank you, everyone. We've got an exciting lineup of speakers and events planned for today's conference, and we hope you will find it engaging and informative.
The nursing department is currently progressing to have international class. He is a video profile of nursing departments of Gorontalo Health Polytechnic.
Nursing Diploma Program of Gorontalo Health Polytechnic prepares vocational nursing graduates who have the ability to provide nursing care as caregiver, client educator, nursing manager, and researcher. Our vision is to become the leading study program in producing nursing graduates who are competitive, having strong character, and excellent in giving nursing care for patients with non-communicable diseases. And to achieve the vision, we break it down into mission. First, conducting and ensuring good quality education and learning process. Outcome-based curriculum, or OBE, has been implemented in student learning to ensure our graduates help fulfill user needs and have global competitiveness. The curriculum is also adjusted to achieve excellence of our graduates to perform high-quality nursing service for patients with non-communicable disease. Most of learning method using student-centered learning approach that sets students to actively involved in the learning process. Next one, to carry out research and community service focusing on non-communicable disease management who have contributed directly to improvement of community health. And finally, to develop partnership with many institutions or other stakeholders to support the implementation of 3 pillars of higher education, namely education, research, and community service.
The learning system in Diploma 3 of Nursing Department has implemented student-centered learning method, which provides opportunities for students to be actively involved in the learning process. The teaching staff and instructors involved are those who are competent in their fields in terms of educational qualifications and training. To optimize the learning process, students are well supported by adequate nursing laboratory facilities. These include medical surgical laboratory, maternity, emergency, psychiatric, gerontic, as well as family and community nursing laboratory. In terms of lecturing activity, students are facilitated with lecture rooms and tutorial rooms equipped with air conditioner and LCD projectors. To support learning in the clinic, students are placed in various health service facilities in regional and national hospitals. Students can also access a comfortable library, providing useful reference books and journals. The graduates of nursing students have made various achievements at the regional to national levels in various scientific and non-scientific activities. The alumni successfully secured jobs in various national, regional, and international hospitals.
Hai, Assalamualaikum warahmatullahi wabarakatuh.
My name is Nur Ayin.
My name is Julaiha Haju. We are alumni from Diploma 3 Nurses from Poltekkes Kemenkes Gorontalo.
Now we are working at Eng Teng Fong General Hospital in Singapore.
We are also under the MOH, Ministry of Health of Singapore, and NUH, National University Hospital of Singapore. So we are very proud to be a representative of Indonesia and Poltekkes Kemenkes Gorontalo for the government program, private to private, for Singapore and Indonesia to be nurses overseas. And also we want to say thank you
for the all lecturer of Poltekkes Kemenkes Gorontalo who are giving us guidance, motivation, and direction during our completion of study. The sense given us long as we study is very useful for us after working here and make us confident for compete with the nurses from institution and other countries.
I'm Aprilivia, the first year student of nursing. Regarding extracurricular activities, we are facilitated by various talent development units, namely art, sports, scientific, English club, and religious activities. We are also encouraged to actively participate in various regional and national competitions. To me, it is very challenging, yet very excited to contribute.
Well, I'm Andika, the second year student of nursing program. Apart from talent development, the department also focuses on leadership and teamwork skills. Students are directly involved in several student associations. The academic atmosphere in our campus is very conducive. The learning process is very fun. The lecturers are very friendly and competent in their fields. The staff and employees are very responsive in the serving of students. Thereby, it brings a huge convenience. Ladies and gentlemen, we are now going to have the opening speech delivered by Head of Committee of International Conference on Nursing Update and Healthcare 2023. Please welcome Mrs. Suarli Mobiliu, SKP MCAP.
Assalamualaikum warahmatullahi wabarakatuh. Shalom. Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good morning, ladies and gentlemen. The Honorable Director General of Health Workers of Indonesia, Dr. Gigi Ariyanti Anaya, MKM. Director of Gorontalo Health Polytechnic, Muhammad Anas Anasiru, SKM, MKes. Vice Directors of Gorontalo Health Polytechnic, Head of Nursing Department, the ranks of academics of Gorontalo Health Polytechnic, the head of Alumni Association of Gorontalo Health Polytechnic, all the invited speakers, researchers, practitioners, and participants. I am Suarli Mobiliu, the head of committee of the first International Conference on Nursing Update and Healthcare 23. First of all, I would like to say Alhamdulillah, because it's this morning we can gather in this building. Furthermore, before we get started, I would like to extend my appreciation for the hard work of entire committee and all parties and participants who have supported so that this event can be carried out and hopefully it would run smoothly and provide many benefits. In this sense, allow me, the head of committee, to report several things. This event is titled the First International Conference on Nursing Update and Healthcare 2023, Raising a Theme, Health Transformation and Management of Degenerative Disease. The initiative of this event is based on the degree of the Director of Gorontalo Health Polytechnic regarding its establishment of committee of the first international conference on nursing update and healthcare 2023 sets out the Department Nursing of Gorontalo Health Polytechnic to host the conference. Purpose. The main purpose of this conference is that to establish a forum to exchange ideas regarding health transformation and its relation to degenerative disease. Speakers. The speakers of the conference come from 5 different countries and institutions worldwide, namely Professor Makoto Oi, PhD, from Kanazawa University, Japan. Professor Sudat Warnakula Surya, PhD, from University of Colombo, Sri Lanka. Dr. Lee Wan Ling, from University of Malaya, Malaysia. Professor Sing Mei Chen, PhD, National Cheng Kung University. Dr. Debbie Dahlia from Universitas Indonesia. Andi Masita Irwan, PhD, from Universitas Hasanuddin, Indonesia. Participant, there are 570 participants from Indonesia, including lecturers, practitioners, and students. Time and place. This international conference is held on the 24 and 225 of August 2023, conducted virtually via Zoom meeting and broadcasted live on YouTube channel of Keperawatan Poltekkes Kemenkes Gorontalo. Source and funds. This event is financed from the DIPA Politeknik Kesehatan Kemenkes Gorontalo 2023. That concludes the committee report. Thank you very much for your participation, and I wish you a very successful conference. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Mrs. Suarli Mobilio.
Now we are going to listen to welcome speech given by Director of Gorontalo Health Polytechnic. Ladies and gentlemen, please welcome Mr. Muhammad Anas Anasiru, SKM MKes.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon us. Halom, Namo Buddhaya, Om Swastiastu, Salam Kebajikan. The Honorable Director of Directorate Health Workers, Mrs. Arianti Anna, Dr. Gigi Arianti Anaya, MKM, distinguished speaker, delegate, ladies and gentlemen. It's a great pleasure and honor that I stand here today as the Director Gorontalo Health Polytechnic to welcome you all the first International Conference on Nursing Update and Healthcare 2023. This forum gathers brilliant minds from around the world truly embodies our shared commitment to advancing healthcare system and facilities. I would like to extend a special welcome to our esteemed speakers who have graciously accepted your invitation to share their expertise and insight with you. Their collective knowledge and experience in the field of health science are invaluable, and we are privileged to have them today. We have Professor Makoto Oi, PhD from Kanazawa University, Japan. Professor Sudat SP Warnakula Surya, PhD from University of Columbia, Sri Lanka. Professor Hising Wen Chen, PhD, RN from National Cheng Kung University, Taiwan. Dr. Li Wangling from University of Malacca, Malaysia. Dr. Dewi Dahlia SKP MSM from Universitas Indonesia, and Andi Masita Irwan, PhD from Universitas Hasanuddin, Indonesia. This conference holds tremendous significance as we focus on the topic of health transformation and management of degenerative diseases. The implementation of a health system that focuses on health transformation currently emphasizes improving people's behavior and self-reliance, professionalism of health workers, as well as preventive and preventive effort without neglecting curative and rehabilitative efforts. We can share insight, research finding, and best practice to combat this pressing issue by coming together. Our collective effort will undoubtedly lead to transformative change in how we approach healthcare issues. I would also like to express my gratitude to all the delegates present here today. Your participation and attendance in this conference reflect your unwavering dedication to advancing the field of health science. Your presence here serves as a testament to the efforts we collectively place in addressing the challenge faced by health workers and finding innovative solutions to improve health quality. Subsequently, I would like to acknowledge the hard work and dedication of the organizing committee and all the individuals involved in making this conference a reality. Their tireless efforts in curating an exceptional program have resulted in this gathering of brilliant minds, and their commitment to excellence deserves of our appreciation. Finally, I welcome you all to this prestigious conference and encourage you to seize every opportunity to connect, collaborate, and exchange ideas. May the next few days be filled with enlightening discussion, faithful collaboration, and valued insight that will shape the future of public health care together. We can make a profound difference and empower future generations. Thank you, and I wish you all a memorable and successful conference. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you to Mr. Muhammad Anas Anasiru, SKM MKes.
Distinguished guests, delegates, ladies and gentlemen, today we begin
Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo. Yang pertama, menyelenggarakan pendidikan dan pembelajaran yang profesional. Yang kedua, menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan. Yang ketiga, menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan Keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia, melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah yang kondusif, adanya laboratorium yang lengkap dan terpadu yang diperuntukkan sebagai laboratorium keperawatan, laboratorium kebidanan, laboratorium gizi, laboratorium farmasi, laboratorium sanitasi lingkungan, dan laboratorium bahasa serta laboratorium informasi teknologi. Ini membuktikan bahwa Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap menjadi pendidikan tinggi vokasional kesehatan yang terdepan dan unggul dalam menghasilkan tenaga kesehatan. Politeknik Kesehatan Kementerian Kesehatan Gorontalo akan terus berkarya dan senantiasa berusaha menjadi institusi pendidikan tinggi vokasi kesehatan yang kompetitif, unggul, dan berkarakter.
Ladies and gentlemen, we apologize for your inconvenience. We will continue to the next agenda.
Ladies and gentlemen, our next agenda is prayer that will be delivered by Mrs. Suwarni Loleh, SST MKes.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, let us bow our head for a moment, pray to God Allah Subhanahu wa Ta'ala, so that our international conference can be precious to all of us. I will lead this prayer based on Islam, and those who are not Muslim, you are pleased to pray according to each of your beliefs. Bismillahirrahmanirrahim. In the name of Allah, today, Thursday, August 24, 2023, in this beautiful place, we gather here to bring about an international conference on nursing update and healthcare. The theme is Health Transformation and Management of degenerative disease. Make this international conference as a useful science assembly, as a medium of sharing useful ideas, knowledge, and experience of scholars, researchers, and students of various disciplines. May the conference we organize today benefits to our lives, broaden our knowledge, shine our ideas, and lead us to be successful, productive persons, which in turn will boost dignity of our nation. Oh Allah, guide and bless our hearts and minds with the lights of your guidance. Impart your supreme wisdom upon our activities. Help us to speak our minds clearly. Help us to listen to each other, respect each other, love each other, so that we are included to the blessed persons. Oh Allah, protect us from unintended temptation. Show us the right path and give us knowledge and strength to perform good things. Show us and make it clear the bad things and give us knowledge and strength to avoid them. Oh Allah, you are the one who can fulfill our hope and prayer. Amin ya Rabbal Alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Before we move further to the next agenda, the committee would like to extend our gratitude to the sponsor of the conference 2023. Our supporting partners, the first one is Indonesian National Nurses Associations, Bank Syariah Indonesia, Bank Sulutgo, Prodia, Mitra Keluarga Sehat, LKP Cendekia Indonesia Training Center, PT Aslin. Thank you for your cooperation.
Ladies and gentlemen, now we are going to have a session 1. The session 1 will be moderated by Mr. Muhammad Arif Ismail, SPD, MA TESOL. Over to you, Mr. Muhammad Arif Ismail.
Thank you. A very good morning to ladies and gentlemen. Welcome to the first International Conference on Nursing Update and Healthcare 2023. My name is Arif, and I'm your moderator for this very first plenary session. On behalf of the committee, we are delighted to announce that we have a very outstanding lineup of speakers today. And just before we get into the presentation, allow me to briefly introduce you to our first speaker today, Professor Sudat Warnakula Surya from University of Colombo, Sri Lanka. He holds a master's degree in nursing from University of Adelaide, Australia, under WHO scholarship 2003. Then he obtained his PhD degree in 2014 from University of Sri Jayawardenepura, Sri Lanka. Professor Warnakula Surya was awarded by the National Research Council for 2 consecutive years, 2013, 2014, and also 2017 under Presidential Award Scheme. Furthermore, he contributed immensely for all nursing professionals, organizations, and trade unions as a guest speaker and a motivator for thousands of nurses in Sri Lanka. Professor Warnakula Surya also involved as a resource person for the Ministry of Health to result various policy decisions, forums regarding nursing, and being a chairperson for program review committees at Ministry of Higher Education. During the past 8 years, he has been an executive council member of Organization of Professional Association and maintaining very prolific research profile with more than 40 publications. His research interests are work economics, occupational health, musculoskeletal disorders, particularly nurses' health. Ladies and gentlemen, I would like to invite Professor Siddharth Warnakula Surya to deliver his presentation. Over to you, Professor.
Thank you very much for the kind introduction. Am I audible?
Yeah, audible, really clear.
Yeah, can you see my presentation?
Yes, we can see that, very clear.
Right. First of all, I would like to thank for the organizing committee of this first international conference for inviting me as the guest, one of the guest speaker. And also I have been given a topic related to your conference theme. I have selected, according to my understanding, that rising tendency of neurodegenerative disorders and impact on healthcare system. Why I have selected this topic is this is a global health problem in the world at the moment. There's a rising tendency. We can observe the trends. There are many neurodegenerative conditions on rise. So therefore, I have selected this area to discuss about rising tendency of neurodegenerative disorders. Right. During my presentation, I would like to discuss with, since this is a very complex area, there are many areas to be covered, but I have selectively identified some important areas that should be relevant to nursing profession, and also little bit about management strategies and current situation. And also I'm going to highlight the impact on healthcare system. Neurodegenerative disorders continue to be leading cause of the disease worldwide today, and also their contribution to overall burden of from health condition is increasing. That is the major reason you also have selected degenerative disease as your theme. Right. When you come to this area, neurodegenerative diseases, the progressive loss of function as well as structure of the neuron due to known cause or unknown cause. There are certain causes we cannot identify, including death of neural cells. And many neurodegenerative disorders are discovered, which are the result of degenerative process in which Parkinson's disease, Alzheimer's disease, and Huntington disease are the most common disease condition. But there are many rare neurodegenerative disorders are there, but we will just have a look at all these things. This is fatal, not curable, and also permanent in nature, resulting in a debilitating situation for the patient. Therefore, people with these disorders they contribute to major disease burden to the world, society, and family and community. Right. If you see the statistic, the number of people living with dementia worldwide in 2015 was estimated at 47 million. You see the rising trend now, right? Reaching the 75 million in 2030, and that will be reached again 135 million in 2050. Therefore, this is the high time discuss this matter and give general awareness among healthcare professionals to get ready and prepare for this one. Currently, more than 55 million people live with dementia worldwide, with over 60 living with low and middle income countries. That is the most important thing we have to highlight. Not only that, there are nearly 10 million new cases every year join into this disease group. When you come to dementia, this is a part of dementia type. Alzheimer's disease is the most common form of dementia may contribute to 60 to 70% of cases. That is one of the major challenge in most of the countries. Even USA, they have clearly estimated that large number of people with Alzheimer's disease, and they are in the process of developing new treatment strategies and management strategies. If you come to our Sri Lankan context, I have just identified that by the year 2050, there will be almost 500,000 people living with dementia in Sri Lanka. Therefore, that's a great burden to Sri Lankan healthcare system. If you generally look at the causes of neurodegenerative disorders, the age is major factor, because when you are increasing the age, you are more prone to get degenerative disorders. There's a genetic relation, genetic factor, and also there are many environmental exposures can contribute to neurodegenerative disorders. There are research evidence. And also, if you look at the medical history of certain disease conditions, have some kind of contribution to developing neurodegenerative disorders. Habits, routines, and choices of people, that is a major determinant factors, and also those are modifiable risk factors. Even we can modify and reduce the risks of developing neurodegenerative disorders. Is that my face is too fast or slow or medium, or should I make it change? Is it okay? I'm asking from the audience.
Yeah, it's fine so far. Go ahead, Professor.
Right. Right. What is neurodegeneration? A slow and progressive loss of neuronal cells in specified regions of the brain of unknown cause. But for different disease condition, the affected area may be different when you investigate properly. And also, hundreds of different disorders with attention mainly focused on only a handful. That means Alzheimer's disease, Parkinson's disease, Huntington disease, or Huntington chorea, we call chorea sometimes, and also amyotrophic lateral sclerosis. That there are many other very rare neurodegenerative disorders. You know that neurodegeneration always involved in neuron cells, and there are many changes after degeneration. Dysfunctional areas you can identify easily if you go for very strong microscopic investigation. Right. There are many types, as I mentioned. I have identified most common types. Alzheimer's disease, that is commonly found everywhere in the world. Parkinson's disease, there is another problem, but that is not so common like Alzheimer's disease. But Huntington disease is a very typical disease condition. If you see the person, you can identify he has different kind of body movement, jerking situation. You cannot stay around with the person because he has no any control regarding his body movements, sometimes special jerks. Right. There are some other uncommon conditions, nice to know. Spinal muscular atrophy, and also multiple sclerosis, and amyotrophic lateral sclerosis, or sometimes called motor neuron disease, and transmissible spongiform encephalopathy, that is also called Wilson disease, and prion disease. Sorry. Another type is spinocerebellar ataxia. Those are rare conditions, but that is come under the category of neurodegenerative disorders. As I mentioned at the beginning, there are many other very rare degenerative disorders being identified in the world with various research. Right. What is happening during the neurodegeneration? Then gradually you can see the green head. Then when the person becomes old, there is a loose areas in the brain. The condensity or cell reduction with the degeneration can be observed is a sign. If you can see this, normally we know we are undergoing the aging process. We are at more risk when you are leading to increased age. That is why the problem is considered as rising tendency. There's a major reason because, as we all know that, all nurses know that, there's an increased tendency of age population in the world, everywhere in the world. There is a big problem. There's a global problem, global health problem, increasing aging population. Parallel to this increased aging population, large number of neurodegenerative disorders going to be increased. Right. The major challenge is this increasing rise in tendency like dementia-like disease conditions in low and middle-income countries, not in high-income countries. Therefore, we have focus special attention in Asia, especially the low and middle-income countries. If you see the blinded and aging population, that is common to everywhere in the world, high-income countries increasing very high, and also China. Typically, this Chinese study have identified as reference. If you see the world scenario, you can see everywhere in the world, aging population is increasing high rate. By the year 2050, we can see this would be a great problem in the world, because in addition to the other chronic disease condition deal with the neurodegenerative disorders, large number of people will occupy the hospital beds. That therefore there can be a great impact on healthcare system in the world. When you talk about the most common condition, Alzheimer's disease, with the age, there is a sharp trend of increasing after 75 years. That means people who are living longer definitely have high risks of developing this condition. Europe is the highest level, and also USA and other countries. In Asia also, this trend is increasing very sharply. Right. Hallmark of neurodegenerative disorders, it is believed that deposition of the apparent protein aggregate in the brain are recognized hallmarks of major degenerative disorder. Not only that, they may occur due to age and also environment factors, and also due to genetic mutation which impacting central nervous system. All these microscopic presentations are not so relevant to nursing, but nice to know. If you are interested in, there are different websites I have identified. Later slide you can see. If you are interested in, you can read and further understand the things. There's important statement I have identified. Two achievements of the human intellect from the last decade of the 21st century is quantum cosmology. That is the new science of the universe. The neuroscience, the new science of the brain, the former proves our beginnings, the later our destiny. Our destiny determined by the neuroscience and also neurodegenerative disorder. Therefore, there's an advanced neuroscience investigation currently in progress to identify the pathological involvement, changes, and also diagnosing factors, and identify new drugs to control disease, and also new drug to limit the progress and provide the proper treatment. Right. This person is Dr. Alzheimer. This person who identified the Alzheimer disease is a major neurodegenerative disease condition in the world. Millions of people suffer from this disease condition. Billions of the dollars are spent on neurodegenerative investigations, but mainly targeting the Alzheimer disease. That is the biggest global health problem in the world. Right. If you see the normal brain and the disease brain, you can see there are many changes you can identify easily with the brain. If you open the brain with the dead person, there are many loose spaces in the brain, and also atrophic changes you can see the left side and right side of the, if you see the right picture. Right. If you take slides of the brain, also you can easily identify normal brain and the Alzheimer brain, because there are different areas, more spacious areas become because of the degeneration process. Right. Neurodegenerative disease mechanism, loss of neuron degeneration first thing, and also genetic factor mainly contributes for some people. Human system involving, especially when you come to different selected disease condition, immune system involved, and also environment. So, if you are going for any intervention to control this disease condition, you have to consider all these factors and go for investigation or research. Right. I will briefly describe this is nice to know area. Alzheimer's is loss of decrease in the memory. As nurses, we should know what are the major changes. You can learn even from medical nursing textbooks, but just I have mentioned some changes, signs and symptoms of the people with this condition: loss of the memory, alteration of the frame of mind and activities. The most common and frequent cause of dementia, disorientation and aphasia. But disoriented people very difficult to deal with dementia patients because nurses are get exhausted because of this kind of patient, and also we have to have better understanding about the disease condition. Then only we can care properly, plan care and patient-centered care. Parkinson's disease, of course, you have learned this one sometimes in the medical nursing, associated with movement disorders like tremors, rigidity, tachycardia, and also postural instability and both rest position, both in rest position as well as functioning situation. They have walking difficulties and it. But this typical Huntington disease condition, we call sometimes in psychiatry, this is Huntington chorea, choric situation. Atypical neurodegenerative disorders, the CNS are characterized by choreotic movements. Always person have different jerky movements and they can control that motor changes. Dementia, behavioral affecting and psychiatric features you can identify. Mostly the symptoms appear between 30 to 55 years old people, although the onset may occur at any time in the childhood. But when you go to psychiatric area, you cannot easily find this choric patient, Huntington chorea. Very rare disease condition, but very rare you can find these people. And also, the spinal muscular atrophy, that is another major condition. This is group of neuromuscular disorders that result in loss of motor neuron and also progressive muscle wasting, deterioration of the muscle bulk. People lose their muscle density, muscle weakness associated with much twisting, deglutizing of the muscle may affect, leads to difficulty in solving problem. Also, scoliosis and joint contractures also can be identified with these people. I'm not going to elaborate all the things. Rare conditions are there. I will just common condition, multiple sclerosis. That condition is autoimmune and inflammatory demyelinating disease, that CNS system, central nervous system, in which insulating or cover of the nerve cells in the brain and spinal cord. Those are the areas damaged. Physical, mental, and psychiatric problems you can identify with the patient. Specific symptoms are double vision, blindness in one eye sometimes, muscle weakness, and trouble with sensation and coordination. All these disease conditions are having major problems with the patients and who need total nursing care. And nurses should be alert when you are dealing with these people because they have motor control issues as well as they are at risk of falling and we meet with an accident, or there are risk factors that lead into risk for injury, nursing diagnosis sometimes. Therefore, we have to be very careful regarding this kind of field. And most important thing is management is early diagnosis. If you can diagnose the person early, I will discuss some diagnosis tests are available at the moment. Early treatment, preserving the quality of life. According to current evidence, there are no wonderful medicines that you cannot control or easily prevent the disease conditions, but there are certain drugs you can control to some extent. Some symptoms can be controlled to some extent, but the quality of life is always affected. of affected in this people. Research early biomarkers or neuro protection is one area has been focused. Currently, there are more than 261 big trial in order to identify new medications, and a lot of dollars and millions of dollars are spent on this area because it's a big problem in the well-developed countries than developing countries. Unfortunately, the rising tendency is higher in lower and middle-income countries. If the well-developed countries identify the new drugs and medications, then we will get benefit. Otherwise, in low-income countries, very difficult to handle this situation. Only we can look after the people by providing the basic needs and symptomatic treatment. Right. Neurodegenerative disorders, a major challenge in the world. As I mentioned, integrated management should be there. There should be team. You have to identify the team. You have to develop the team, and also you have to give the correct knowledge for the team. And tools and devices need to be identified, specifically targeting the different disabilities of the people. If you come to dementia or Alzheimer's disease, there are newly developed new devices that can be utilized to make the life easy for the patient as well as make the life easy of healthcare provider. If you Google search, you can identify various new devices are there. Even when you are giving the health education, you can provide that information to the family members. They can buy all these new devices to facilitate the people with disease condition, and they can make their life easy as well as patient life easy. Information transfer, decision making, very important, because this knowledge is not there. Even general nurses, you need to have specific knowledge, and we have to prepare the healthcare professional for the future to deal with neurodegenerative disorders, because we are going to face this challenge in the future. With by the time of 2050, we are going to face a big challenge in the in the world with large number of patients with neurodegenerative disorders. Right. If you talk about prevention, I have selectively identified. I'm going to nursing area later. Develop strategies. We have to start now. Policies, plans, guidelines to support these pathologies as well as improve the quality of life of the patient. You need conduct. You have to involve in research and finding the solution for this problem. That's the correct time. That is why you have identified this topic as the most important, significant theme for the conference this time. Raising awareness is an important strategy for reducing the disorder and treatment gap, and also different media channels we have to identify. We have already started, and we are in the process of making aware the people and general public. We have started different media campaign even in Sri Lanka. Film, televisions, internet, and social media you have to utilize to make the people aware, make the patients, guardians, or the relatives aware, make the general public aware, because they are prone to get this disease in the future. If they have more awareness regarding this thing, they can facilitate their loved ones in the family or in the hospital. And also, there is an urgent need improving awareness. This kind of conference, I think we have to identify the most important things, summaries to provide to the policymakers to go for some kind of policy decision regarding these important tendencies we have to identify in the healthcare sector. Improving awareness, understanding of neurodegenerative disease in order to improve the quality of life and also people with dementia and their caregivers. Awareness raising and improved understanding of the reduce the stigma. Sometimes stigma is attached in our communities, sometimes some cultures with this kind of disease conditions because of their abnormal behavior. Sometimes people wrongly understand this is psychiatric illness, sometimes psychiatric symptoms are there. That is why we need to have a better understanding. Neurodegenerative diseases are a global public health challenge, and also that urgent action is required to support currently preparedness for the increasing burden and cost of dementia. Dementia is a major one, but there are other diseases. But That is main focus is dementia and Alzheimer's disease. Promotion of health behavior, series of physical and mental activities on the daily basis, and also contribute to cognitive ability and maintenance of healthy mental functionings, such as exercising in mind, be social and healthy eating, and stress and sleep balance. All these things are things we can educate people to prevent this kind of risk factors. People who are at risk of developing, all people are at risk, but there are a genetic association. But better to understand everybody regarding the same. Parkinson disease is one of the topic under nursing curriculum. Even you know that pharmacologic management you have learned in the third year. Non-pharmacologic strategies are there. Surgical therapy available at the moment. Physiotherapy, occupational therapy, and all these strategies are available for Parkinson disease management. But when you come to diagnosis, there are different new imaging techniques as well as blood investigation. Gene techniques are there in different countries. They have well developed smart diagnostic mechanisms available in the world. This is some pathway has been identified, like alteration in synaptic cleft area in the neuron, inflammatory reaction, oxidative stresses. You can determine that deregulation of the mitochondria, that area can be studied in different investigation. Phenomenon of key, that is pronunciation difficult sometimes. These things you come into investigate the disease condition, and now various new techniques are available and new investigation strategies are there to identify this condition. As I mentioned, these are some tests available, nice to know area, but nurses also can have some idea, because in future you can expose to this kind of new investigation methods for screening purpose. Neurodegenerative disease orders, there are two type of assessment strategies, and also testing of function of language. There are different tests we can utilize all these things. Right. The four focus strategic focus area: lifelong, countrywide care and support. That is the mental preparation we have to have. These are disease condition, lifelong prevalence is there. Countrywide care should be organized and prepare the nurses and the hospital for this thing, or otherwise any other separate institution. Even that in Western countries, in the Europe, you can have dementia centers separately. Dementia specific organizations are there for supporting people. That kind of mechanism should be there countrywide and support the people until they die. There should be a good quality of life. Encouraging societal adaptation to the issues surrounding neurodegenerative disease and reducing the social and personal consequences on the daily life. That is also important. There can be different strategies from the beginning. You have to start and get ready, and preparedness is very important. Developing and coordinating research on neurodegenerative disease. The scientists, those who are involved in scientific research, need to focus on this area for any development in any aspect of caring process or management process or nursing care, any area. There are many improvement needed for this kind of disease condition. Turning the governance of the plan into real tool of innovation and management, public policies and health democracy. These are the major four areas identified in the world to go forward with focus in the neurodegenerative disorders. If you see the common symptoms and problems, those are very important for nurses to make in their nursing diagnosis, and thereafter they can prepare their nursing care plan accordingly. Loss of memory, of course, we know that they are dealing with people with loss of memory. Muscular rigidity, patient muscular rigidity, you can deal with in mental health area, psychiatric area, or other places. Sleep disorders, people have sleep disorders. You are dealing with sleep disorder, other patients. These people also, depression, common mental health problem, but is still with the people with neurodegenerative disorders, they have experienced depression, postural and pace impairment. This is common in neurodegenerative disorders. Psychiatric symptoms like hallucination, delusions, common in some dementia people and also Parkinson people. Constipation is very common because they are not taking much water and also they are not complaining regarding their thirsty, and there are different contributing factors for constipation. Bradycardia changes, bradycardia, and also cognitive impairment. That is the major problem when you are dealing with people with neurodegenerative disorders, because cognitive impairment can contribute impaired communication, impaired judgment, impaired functioning, and also impaired perception, everything, impaired memory. There are many factors related to cognitive impairment. Pain and fatigue also experienced by these people. Therefore, there should be remedies to deal with pain and fatigue. Rest and tremor. Rest tremor is there. People need help from the nursing professionals. Autonomic dysfunctions can be there with the people with these disorders, that we need to facilitate them. Olfactory dysfunctions, therefore vision issues are there. Mood disorders from time to time, up and low moods are there. Accordingly, we can make nursing diagnosis, and accordingly we can plan our nursing care with common signs and symptoms. By medical management, as I mentioned, there are different. This area is nice to know for nurses, because you don't have to be very expert in the management, but definitely you are getting the direction of the medical or a psychiatrist to give particular drugs to the patient, administer drug, but still you need nice to know that Parkinson's disease, there are different dopaminergic drugs, levodopa and other things. Cognitive disorders, always there's a choice of drugs and cholinesterase inhibitors. I think we have to deeply understand the pharmacology related to this area. Behavioral and other symptoms of dementia, antipsychotic drugs sometimes used carefully. Pain, and you know that pain and fatigue we can use with the analgesic drugs, and the associated infection you have to use appropriate antibiotics. And tremor and refractory movement disorders, deep brain stimulatory drugs also there. In the line, there are many other strategies for various neurodegenerative disorders. I am not going to much elaborate that area because our main focus is stick. As I read that new invention or new invention or new management strategies, I found that medication in development for neurodegenerative, large number of research, as I mentioned, 261 clinical trials are in progress, and large number of clinical trials have been come to at the application and submitted level. When you come to dementia, there are many few studies. Alzheimer is the main focus in most of the countries, but multiple sclerosis also 33, and Parkinson's disease also 64. There are many clinical trials in different level, phase 1, phase 2, phase 3, and application and submission level is there in the Alzheimer's disease, because during the past 2 decades, large number of research went on, carried out in targeting the Alzheimer's disease. As you all know that one of the former president in USA, Ronald Reagan, got this disease condition. Because of that, America paid special attention, because they identified the rising tendency of American people to get this disease condition. Therefore, they have spent a lot of dollars for this thing. Right, as I mentioned, there are very new technologies. You can see this. I have selected one picture. They have very carefully looking at the brain structures and new technique, anatomy of the organ functions can be identified with this kind of new imaging techniques. Very clear, and also you can easily identify very small, tiny things in the brain, and changes can be identified easily. Those are new techniques under new invention. Mode of action of this phytochemicals, that is the area in other research, because they have identified that this inflammation and oxidative stresses can contribute to neural disorders. Therefore, they are in the process of conducting investigation and identify the new strategies to control the disease condition. Still, literature say that there are no effective treatment to completely cure the disease condition, but certain symptoms can be controlled to some extent with the disease. Now, you know the impact of these disorders in the healthcare system and the world. We don't have to discuss much, because very easily you can understand that if somebody gets this kind of disease condition, then we have to spend the latter part of the life with the disease condition. There should be carers, there could be treatment, there should be place to look after these people, high cost involved in the family, in the society, in the hospital, and also in the country, in the world. Therefore, that directly lead to global disease burden, and also you can easily identify burdens of disease by calculating the disability adjusted life years of the people. That criteria is there. I think you nice to know that disability adjusted life years criteria. Then you can identify these people with the disability, they are going to stay longer in the world, and there should be carers, there should be a mechanism of controlling, medicine, and also institution, and cost involved in food and basic needs. Everything is related to this impact. Limitation in functional ability and motor symptoms have severely impact in the quality of life. We are more concerned about our quality of life all the time. The people with this disorder, they are losing their quality of life, and finally, that contribute to carers' quality of life, because caregiver burden also associated with this kind of dementia and other disease conditions. That is why we have to have some kind of alternatives to overcome these associated challenges. Caregivers and family members of these patients can be physically, mentally exhausting, especially nurses, leading to enormous stress, fatigue, anxiety, and ultimately depression and financial burden even. And not only that, Parkinson's disease is needed care for the physical limitation of the people, because they cannot walk properly, and you are getting exhausted, and also they are experiencing some psychotic symptoms. Then there are many challenges carers and population in the hospital or a family or the community. Right. Other side of the scenario, because if you look at the dementia itself, what is the cost involved in dementia that has been identified? US dollars 1.3 billion to trillion to 2.2 trillion when you reach the 2030. That means within short period, within nearly 11 years, this rise in tendency can be easily understood. There is a WHO estimate. 50% costs are for informal care, not to treatment even. That is the major problem, because maintaining the hospitals, maintaining the proper carers for this thing, appropriate treatment strategies. Without appropriate treatment strategies even, the informal caring is because most of the well-developed countries like Europe, this problem has been identified very early, and they have made different strategies to give the good quality of life for the people with training and training programs and healthcare professionals development, and also user-friendly or a patient-friendly environment have been developed, and new technology have been incorporated care. There are many things happening in the world. I have no any idea about Indonesia, how you are dealing with this kind of disease condition, but I know that in Sri Lanka, we are in the process of developing some educational programs and preparedness is in the progress. You can see different estimates have been made by the 2000 different organizations. They have detected this predicted cost involving this dementia and Alzheimer's diseases. And also, forecasted global cost is gradually increasing, that the rising tendency you can identify very easily. Global cost of dementia, US dollar millions, increase day by day, year by year. Now, we come to the nursing aspect of the neurodegenerative disorders. As I mentioned, there are many disease conditions, but several few common conditions. Hello, did I lose? Can you hear me?
Yes.
Can hear you. Yeah.
Yes, we can.
Right. Impaired memory, one of the major problem. Nurses can easily assess the different level of memory, and then accordingly you can go for your nursing diagnosis. Impaired memory, many people have with the neurodegenerative disorders. The next problem is impaired communication, because they have no memory, they are not oriented, they are not organized, then communication is affected. Therefore, we can make a nursing diagnosis initiating with impaired communication related factors can be added, and also evidence by other factors you can add. Then you can make a proper nursing diagnosis. We have to focus on impaired memory. Not only that, impaired perception. Some disease condition of these neurodegenerative disorders, people experience hallucination, delusions, and other psychotic symptoms. Then perceptual alteration can be there, impaired perception. Then you have to make a nursing diagnosis, and also accordingly you have to behave according to the patient's symptoms. Otherwise, there can be conflict or arguments or fight with the nurse even. If you cannot understand the perceptual alteration. When come to impaired thought process, as I mentioned, there are many delusional thoughts come to their mind, and also especially dementia patients. With Alzheimer's patient, you can identify then the nursing diagnosis proper for impaired thought process related to the disease process, evidenced by they are telling different delusional ideas. Risk for force and injury is very important for nursing. That is a nursing concern. Most of the people are more prone to fall and get injury. Therefore, potential nursing diagnosis you can make with the patient with these disorders, especially Parkinson's patients, risk for falls and injury. Right. Impaired mobility, that is also common nursing diagnosis. I have typically identified this area in the assessment. You have to look at the mobility level of the patient. Accordingly, you have to support mobility devices are there sometimes. As I mentioned, even you can buy from the shop and you can order online. Even nowadays, there are facilities to different people's impairment. There are different devices. Right. Situational low self-esteem, that is another nursing diagnosis, because person who have some kind of memory or understanding, they feel low self-esteem because they had been there in life, in a wonderful life and wonderful employment. Sometimes when they fall this kind of disease condition, fall in this kind of conditions, they always regret regarding their previous capabilities and their image and everything. Therefore, they feel that situational low self-esteem. Therefore, all of the nurses to improve the self-esteem by identifying the strength of the person and so reassuring the person. These are major focus areas, but of course, basic needs and other problem you have to identify. When you come to this caring dementia or people with neurodegenerative disorders, caring conceptually defined as human trait. Moral imperative, very important, and also interpersonal relationship and therapeutic intervention. Whatever the things we do, that should be therapeutic effect to the patient. Therefore, our communication should be therapeutic, our reaction should be therapeutic, our feedback should be therapeutic, and also our intervention be therapeutic. People with neurodegenerative disease commonly treated in mental health care settings or psychiatric hospital. Most of the time in Sri Lanka at the moment, we don't have separate dementia institution. Might be there in your country, but other countries, of course, they have. Right. When you come to psychiatric nursing, there are two wonderful areas we have to focus on. The specialized area of nursing practice employing theories of human behavior as its science. If you are going to deal with patient with neurodegenerative disorders, first most important thing is you should have better understanding about the theories of human behavior. That area you can learn from psychology, or otherwise specifically you have to learn in psychiatric nursing. If you know correctly the theories of human behavior, that you can use it as science of your care. And when you come to the other part, purposeful use of self as an art, as its art, then you have to use yourself as an art. How do you do this thing? Then you have to develop all the skills related to caring people with neurodegenerative disorders, because communication, specific communication, therapeutic communication, different therapeutic techniques you have to use to communicate with these people, and also broad awareness regarding how to do. Then if you have both things together, only you can be a good carer to the neurodegenerative disorders. Therefore, you need to have specific education or preparation other than just a caring psychiatric patient even. That is why we have already initiated one is specialization in nursing. We call it neurodegenerative care, masters in neurodegenerative disorders. We are in the process of developing, but it's still not completed. But that is the focus in every area in the world, especially Europe. That is one specialization in nursing in future. That is a great demanding area. Even you can take initiative regarding this thing. Even we can help your organization if you are in the process of that kind of in the diagnosis and treatment of human responses to actual or potential mental health problem. So these two things complete the psychiatric nurse. But if you specifically identify the purposeful use of yourself as a nurse, definitely you need to learn more and develop more skills in your competencies. As I mentioned, there are many organizations, international NGOs, to facilitate neurodegenerative disorders, and also information provision, and also different guidelines, advocacy, and everything. Better to follow this thing. Those who are interested in neurodegenerative disorders, I have just highlighted for nurses to develop their knowledge. As I mentioned previously, we are in the process of world project that is called Neurodegenerative Neurocare, the European Initiative for Capacity Building to meet challenges in the caring for people with neurodegenerative disorders. There is initiation with Faculty of Nursing, my university, University of Colombo, and main university, Christian University, Sweden, and we got the support of very big expert group from different 8 universities in the world. 4 universities from our country, and also other countries. We got Cyprus, we got Slovenia, then again the Nepali University, Estonia, and different other 4 expert knowledge we are going to incorporate to develop this capacity building, because we need to develop nurses specifically for this kind of disease. It is very difficult because we are facing this challenge in future. Therefore, we have to get ready now. We are going to complete this project in 2025, and we are in the process of making aware the people regarding the neurodegenerative disorders. We have different campaign at the moment, and I have shown here in the slide different campaign and TV programs. World's in Alzheimer Day, we carried out a program, and also dementia in the National Institute of Mental Health. We had carried out a program for healthcare professionals as well as lay publics, those who are having patient with this condition, different neurodegenerative diagnosed disease condition, different programs in the process, and also that should be done preparedness. Right. I'm reaching to the final stage of my presentation because there are many areas to be discussed, but this is not the correct time talk everything, but if you have any specific questions, I can answer. There's a popular lady called Rosalind Carter. Carter mean one of the former president in USA. Jimmy Carter, his wife is Rosalind Carter. That lady has divided these people in the world in terms of caring, because we are the people carers, nurses are the people caring for any disease condition. Nursing care is very important. Nursing has been recognized as a wonderful profession today in the world, and also there's a good recognition given to the nursing in the world. And also there's a there are different new strategies to uplift nursing profession in the world, because there's a huge demand as well as big shortage in the world. During the last ASEAN conference, we discussed separately the big challenge we are facing in the most of the developing countries, because they are nurses leaving to the other well-developed countries for there are many vacancies, and also there's a big shortage that created, that predicted level of shortage that come to 13 million nurses by the year 2030. Therefore, we have to. But this person say wonderful thing. Nice to share with you. Those who had been caregivers, we can divide people in the world into 4 categories. We are caregivers, but we are talking about those who had been caregivers earlier, those who have retired nurses, maybe those who have cared their parents or elderly people earlier. Other categories, those who are currently caregivers like nurses, nursing students, at the moment those who are caring their patients or family members. Other categories, those who will be caregivers in the future. Of course, these nursing student groups, they are going to be caregivers in the future, because their main task is to get giving care. Whatever the expertise they obtain, whatever the specialization they complete, but still they are the people going to care people. Final category is those who will need a caregiver. Even though you are not a healthcare professional, one day any person in this world who will need a caregiver. Therefore, this caring is a wonderful thing, and also we have to keep in mind our care is more significant than any other this person has categorized in this. With that note, I just want to thank you again for this wonderful conference to participate as a speaker. Thank you very much for your invitation. If you have any question, I can answer. Thank you.
Right. Thank you very much, Professor Sudat Warnakula Surya from Sri Lanka. Yeah, and thank you for the presentation. And you okay to take some questions, Professor? We've got 2 questions so far. The first questions, do you want me to read all the questions first and then you address all of them later, or one by one, Professor?
I don't mind, you can.
Okay, so I think it's the best one to address the question one by one. So the first question comes from...
I can see the question, no?
Okay, so I'm just going to highlight so everybody can actually paying attention on it. So the question is about percentage. How many % of genetic factor increase neurodisease affect 2 people? Yeah, over to you, Professor.
Sorry?
So the question is about the percentage. How many % of genetic factor increase neurodisease affect 2 people?
Right. That is some tricky question, because some disease condition, because there are different neurodegenerative disorders. If you take Alzheimer's disease or dementia, that also rising tendency is still there, but genetic factor has been identified as contributing factor, but not a big level. I cannot say exactly, but low possibility. But most of the time, highlighted in the literature is our practices, our exposures, our day-to-day practices, our day-to-day, that behavioral conditions. Behavior, I mean, you know, that unhealthy behavior, lack of exercises, physical inactivity, all these factors have been contributed. Therefore, what we have to do, genetic factor is a non-modifiable factor, but there are many modifiable factors we can control the things, because different studies have identified different contribution, but you cannot say gene also differ from country to country. Sometimes there is no common percentage has been given in the literature.
Okay, thank you very much, Professor, for addressing the first question from Faradiba. And the next question actually comes from one of the lecturers from Nursing Department of Gorontalo Health Polytechnic. And she's requesting to speak on the speaker with you.
Right, okay, go ahead.
Yeah.
Thank you. My name is Warli from Nursing Department Politeknik Kesehatan Gorontalo.
Nice to meet you. Yes. Yeah.
My question is there any best practice of Alzheimer management at home according to your knowledge?
Best practice?
Yes.
Yeah. Actually, these are best practice. I have got an opportunity to visit Europe, especially dementia care centers in different countries in Europe. So there are good practices with dementia patients. Their main problem is they cannot recognize the people. They can have memory issues and different dysfunctions in the cognitive level. So, what some practices are practice in the European region is that we should keep the person actively engaged in different activities according to a schedule. Starting with the schedule, in the morning you have the breakfast, then there's a time for you to have some discussion. Sometimes you have time in the schedule. There are past histories you are talking about. We call it reminiscent groups. That means people put together and one person start the talk and he talk about his past history and the employment or the school age. Then other person also get stimulated. Then they talk about their thing, and that engagement is there, sharing. Thereafter, the second thing is you put the people with some musical or some situation like happiness creating. Then you every day you get some opportunity to expose to music, and also other best practices expose the person to the nature. If you cannot take the person all the time to nature, the beach or the garden, you have created within your family or institution some natural environment, like you are keeping the pets around you, the chicken or the rabbits or other people, live animals. In addition, you are putting some fake animals even to keep with these people, and they are giving some stimulation with this thing. In addition, there are newly developed techniques are there. Those techniques actually fiber lines, different fiber with the stimulation. If you touch the fiber, you get the color change, and also person's mental stimulation is there. If you when you touch the fiber, that fiber, you get different colors. Then person concentrate on this thing, and those are very expensive things. But exposed to the nature is one thing, as I mentioned. Second thing is engage in different communication activities, and also according to the person level of capabilities or mobility, you have to give activities according to the patient's considering the disabilities. That means actually throughout the day, different activities and involvement. Keep the person happy, and also all the time mental engagement is required. Otherwise, sleeping all the time is deteriorating very fast. Therefore, actively engage the patient, expose to the environment or natural things, or even artificial things to stimulate the brain. Those are the things I have observed and seen.
Okay, so Mrs. Warli said, thank you very much for your response, Professor. That's such a very detailed explanation. Keep the person happy, that's the key. Right, and for your information, Professor, well, actually, the students in here are really have a lot of takeaways from your explanation from the previous questions, because that's quite detailed with a lot of practices that can be implemented on daily basis. And we would like to inform you that we're holding this conference in an auditorium, and we have hundreds of students with us in here. They following your presentation from the beginning. We will show you on the screen all the students. Yeah.
Right. Nice to see you. Nice to see you all.
Yeah. Okay. Right. They're following your presentation from the beginning, Professor. Okay, and we still have the last question from a nursing student. Okay, nursing student, yeah, we go to the nursing student first. And she is requesting to speak with you.
Yeah.
Okay, go ahead.
Welcome.
Okay, thank you. My name is Adinda Putri Ayuba. I am a 5th-semester student majoring in nursing, Gorontalo Health Polytechnic. According to your presentation, there are several nursing diagnoses for patients with neurodegenerative disease. I would like to ask you how different patients with the impaired memory from impaired thought process. Thank you.
Right, very good. Impaired memory and impaired thought process. Yeah, this is two nursing diagnoses we can make while we are communicating with the patient. Not only the neurodegenerative patients as well as psychiatric patient, we can identify this thing. You have to ask several questions from the patient. First, starting with the long history, his past, his marriage, schooling time, or something very long. We can assess the long-term memory. Then recent memory, within 24 hours, something happened during their life. You can ask, check their recent memory. Again, within 10 minutes time, if you have tell something to the patient to keep in mind, and after 10 minutes, 7 minutes, you can ask whether he can remember this. So if the person can remember the whole history, his past, that is his long-term memory is intact. That means okay. Then if the person can remember the recent thing last week or during within 24 hours, something if you mention, the person can remember, that means recent memory also intact. There's no issue. But if the person cannot remember the things you have mentioned 10 minutes, 7 minutes before, there's a problem in the memory. But in that manner, you can assess the memory. And also, if you find the patient cannot remember anything, we can say impaired memory. We can say impaired memory. When you come to impaired thought process, that is something related to wrongly held misbelief people have, we call delusional ideas. Sometimes people believe that with the mental health problem or a degenerative disorders, some people have are trying to harm them. They try to destroy them. Some people talking about it, that kind of the delusional ideas. If the person has that kind of delusional ideas, we call it impaired thought process. Did I answer your question?
Okay, right. Do we still have more time for questions? Yes. Okay, Professor Sudad, are you okay to take one last?
Yeah, no problem.
Okay. So one participant on the Zoom is raising hand. Miss Ayu, you okay to deliver your question right now? Okay, so we're taking it to you, Miss Ayu. Go ahead.
I cannot hear you.
Okay. Yeah. So the technical team is trying to unmute you. Yeah.
Okay, thank you very much, Professor, for the opportunity. My name is Ayu Cahyaning from Nutrition Department from Health Polytechnic of Gorontalo. I have one question that focusing on the way of how the researchers and government in Sri Lanka prevent or overcome this dementia. Thank you.
Very good question, and also I'm happy to answer because this World Health Organization identify the world trends and they highlight how to prepare the governments or the policymakers to get ready for coming challenges. Of course, sudden problem like corona, you cannot make any decision suddenly. WHO can identify, but this kind of trends have been identified by the WHO. So, in Sri Lanka, there's a separate institution called National Institute of Mental Health. That is the main organization teaching doctors, nurses, and expose the patients, people, those who are undergoing training, providing mental. That organization has prepared some new courses for healthcare professionals to deal with especially dementia-related disease conditions. And also, they did not have separate ward unit for dementia patient earlier. Currently, they have established dementia units separately and provided facilities to expand the facilities to caring dementia and neurodegenerative patients separate location in the same hospital. Thirdly, as a university, Colombo University is the leading university in Sri Lanka. We have initiated collaboration with the European region, Sweden University, to develop new program for specialized in nursing. In Sri Lanka, we don't have any specialized nurses in neurocare or specialized care. So, with their help, we made a request to develop some specialization for graduate nurses to master level. Then, in that program, they connected us with another 4 universities in Europe, Norway and Slovenia, Estonia, and Cyprus, and Sweden. There are 4 universities. Now, we are in the process of developing a new degree program for healthcare professionals, especially targeting nurses. And also, we are giving capacity building training to these selected people in 4 universities in Sri Lanka to go to that well-developed areas in the world and get exposure and learn how they are dealing with this thing in a correct manner. That is why we got some opportunity to visit Sweden and Estonia. Next year we are going to Slovenia. That well-developed countries, they have wonderful caring system for people with dementia and neurodegenerative disease.
Okay. Yeah. Ms. Ayu, you would like to say something? Follow up the question?
Yeah, that's very great solution from Sri Lanka. Thank you very much, Professor.
Yeah, thank you very much, Ms. Ayu. Right, it seems like Professor Sudad, more participants are really interested to best practice and some technical details, daily routines and stuff. And if you don't mind, we still have one last question, Professor.
Yeah, I don't mind. Yes, go ahead.
Okay, sounds very good. So this is a question from Irma Riani, Universitas Indonesia, Indonesian University. So it's about how to involve the family in preventing and treating Alzheimer's disease. Can you tell me how the involvement of families in your country, Sri Lanka, in caring for Alzheimer's patient?
Yeah, very good question. There's a lengthy answer for this one. Anyway, if you have time, I will explain. First thing we tell the people that you have to have attitude for being carer to the healthy mentally the patient with disease condition, because there should be a strong attitudes to this is a dull and monotonous job, because people with the neurodegenerative disorders, they all the time, their behavior you cannot control. They do not recognize you, they cannot identify you. Sometimes there are different memory issues. Therefore, that is challenging for the healthcare professional as well as family members. Then there should be some kind of attitudes to caring, first thing. And also you have to prepare your home patient-friendly environment in the home. That is the next advice we are going to give. When the patient-friendly environment mean family should be there, at least there should be a gate, closing gate when you are entering into the house. And also within the house, there shouldn't be any items or the furnitures that person always hit against that kind of thing. A furniture arrangement should be there. Then toilet arrangement. People have difficulties in movement, therefore there are different gadgets you can fix in the toilets even. You have to fix all these things, then person can easily utilize the washroom and all. Then there are different walk-in devices, well-developed things you can buy if you have, if you can afford. Other thing is, whatever the items they are using in day-to-day life should be recognizable to the person. You can label these things, colorful things should be there, person easily identified, right? Even those who are using the mug, that should be colorful one, red one, or the yellow one, not that kind. Then your room environment, there should be a bed even. Not the low level, not the high level, but the level should be identified according to the patient length of the leg. When you sit on the bed, leg should touch the floor. That is the level you have to keep. Otherwise, what will happen if you keep the person in the lower leg, lower bed, person difficult to get up because you have to have more strength to getting up. Therefore, sometimes people scared of people falling down. They keep the smaller low bed. What will happen? Person take much effort to get up from the lowest bed. But if your foot touch the ground, that means easily you can get up. All these things. And also, there shouldn't be any sharp items around the house that person can get injuries. Those are simple things. And also, all the time, you have to keep other rooms in the family closed because these people wandering, going here and there. At night, you have to keep the door closed, and also there should be mechanism to identify the person leaving from the bed, any bell or something that we can we know that person is leaving or something. And there should be somebody. Yeah. In your ground, in your garden, there shouldn't be any hole that person can fall in, or there shouldn't be any gaps. You are walking very slowly, then you can hit against all these gaps and everything. You fall down. That kind of preparation should be there, and also you have to make aware the family members. This person is not normally understand things. Therefore, you have to tell the things repeatedly. Sometimes you have to memorize the person. Several times you have to give the same answer sometimes. Then you get angry. That is not good because sometimes same question asked repeatedly 10, 20 times, same question. But if you give one answer, two answers, third time you will get angry. That's not good. We have to love the people. They should feel love. That is what.
Okay, thank you very much, Professor Sudat. That is, well, unfortunately, the end of your session. And for the last thing, the committee would like to present to you a certificate of appreciation that should appear on the screen. So this is a certificate of appreciation for Professor Sudat Warnakula Surya for his contribution in this conference. On behalf of the committee, we would like to say thank you very much for your contribution, your participation in this conference.
Thank you so much for inviting me for this wonderful
much, Professor.
Thank you. Wish you all the best. Thank you.
Have a good one. Hope to see you again in the next opportunity.
Right. Okay.
Yeah. Bye.
Bye.
Yeah. So, ladies and gentlemen, we will continue with the next speaker for this first session. But just before we get into the presentation, allow me to briefly introduce you. Allow me to briefly introduce you to our second speaker in this session, Dr. Debbie Dahlia from Faculty of Nursing, Universitas Indonesia, is an expert in the field of medical surgical nursing. She holds a master degree in health sector management from Monash University, Australia, completed in 2001, and a PhD degree obtained in 2013 from Universitas Indonesia. Dr. Debbie has been teaching nursing subjects for a number of years. In the institution she belongs to, Universitas Indonesia, as well as being a nursing practitioner. In the last 5 years, Dr. Debbie has been prolific, producing research in some specific fields of study, including musculoskeletal relaxation technique and quite immensely on diabetic issues. The most recent publication explores the effectiveness of the Berger-Allen exercise in improving circulation and peripheral sensory status toward patients with diabetes mellitus, and also the concept analysis of self-management in patient with diabetes nephropathy. Ladies and gentlemen, I would like to invite Dr. Debbie Dahlia to deliver her presentation about empowering diabetic care. Over to you, Dr. Debbie.
Thank you, Nas Arif. Okay, should I share my presentation by myself or from the committee?
Well, in your convenience, if you think it's more comfortable to share your presentation your own, then we'll allow you to.
Okay, thank you.
So you're going to share your own?
Yeah.
Okay. Yeah, it's now visible. I can see that very clear.
Okay.
Yeah.
Okay, good. Okay, thank you. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. I would like to begin by expressing my gratitude to Director of Poltekkes Kemenkes, Gorontalo, and the Committee of the First International Conference on Nursing Update and Healthcare 2023, who has invited me today evening. Today we gather to explore more about the health transformation and management of degenerative disease, especially in area of nursing. Regarding with this theme, I would like to deliver a presentation and topic that is rarely discussed, especially in Indonesia, namely the artificial pancreas, how nurses are empowering diabetes care through redefining insulin therapy and promoting artificial pancreas. The outline that I will give in the next 45 are introduction, insulin therapy, what is the artificial pancreas, the role of nurses, and the conclusion. Okay, now I would like a little bit explain about the diabetes. What are the basic of diabetes? Diabetes is lifelong chronic condition that occur when the pancreas can no longer make insulin, the body cannot effectively use insulin. Insulin, a hormone made by the pancreas that acts like a key to let glucose from the food we eat pass from the bloodstream into the cell in the body to produce energy. The body breaks down all carbohydrate food into glucose in the blood, and insulin help glucose move into the cell. When the body cannot produce or use insulin effectively, this leads to high blood glucose level called hyperglycemia. Over the long term, high glucose level are associated with the damage to the body and failure of various organ tissue. There are three main types of diabetes. Type 1, this type, pancreas doesn't make insulin or make a very little insulin. Type 1 can affect people at any age, but usually develop in children or young adult. People living with type 1 diabetes need daily insulin injection to control their blood glucose level. If they don't have access to insulin, they will die. We don't know what exactly causes type 1 diabetes. However, research show that the possibility of developing the condition increase slightly if a family member has it. There are also environmental factors such as exposure to a viral infection, which in turn trigger an autoimmune reaction. Type 2 diabetes. The primary indicator of type 2 is insulin resistant. When the body cannot fully respond to insulin because insulin cannot work properly, blood glucose level keep rising more insulin. Unfortunately, for some people with type 2 diabetes, this can eventually exhaust the pancreas. As a result, the body produces less and less insulin, causing even higher blood glucose level. Accounting for around 90% of type 2 diabetes is the most common type of diabetes. Changes in diet and physical activity related to rapid development and urbanization have led to sharp increase in people with type 2 diabetes. Previously, mainly older adults developed the condition. However, due to rising level of obesity, sedentary lifestyle, and poor diet, poor diet, type 2 diabetes is increasing in children, adolescents, and also younger adults. The other type is gestational diabetes, or GDM. It's a high blood sugar that develops during pregnancy and usually disappear after birth. During pregnancy, the placenta produces hormone that can interfere with body ability to use insulin effectively. This is known as insulin resistance, a normal part of pregnancy. However, in some women, insulin resistance becomes too high, leading to gestational diabetes. Okay, GDM can affect the health, the mother and the baby. It can lead to pregnancy-related complication, including high blood pressure, large birth weight babies, and obstructed labor. Diabetes is one of the most challenging health problem in 21st century that is approaching epidemic proportion globally. In 2021, IDF estimates number of people with diabetes worldwide is 537 million, and like to increase to 643 million by 2030. This means 1 in adult has diabetes. And also there are 240 million adults with diabetes are undiagnosed from the diabetes. And in 1 of 5 of the people who are above 60 years all have diabetes. And more than 21 million births are affected by diabetes, and more than 1.2 million children and adolescents are living type 1 diabetes. We can see from the table the number of people with diabetes continue increase and is predicted to reach 782.2 million in 2045. This is very big number. From the table, we can see the number of people with diabetes in Indonesia is 19.5 million. This number places Indonesia in 5th among countries with the highest number of people with diabetes. Of course, this is not something to be proud of, but it is very concerning for all of us. People are diagnosed with diabetes have to concern themselves about variety of issues like daily management complexity, where blood sugar they have to monitor blood sugar, multiple daily finger prick for glucose testing can be painful and inconvenient. And they also needing to administer insulin injection multiple times a day or managing insulin pump setting. Okay. And the other is lifestyle limitation. They need to constantly monitor carbohydrate intake and make adjustment to insulin doses. And also we know exercise can affect blood sugar level. So they have to require close monitoring and sometimes additional carbohydrate intake. Psychological and emotional strain. A diagnosis of diabetes can lead to feeling of isolation, anxiety about the future, and depressive symptoms. The constant management can lead to we call diabetes burnout, where patients feel overwhelmed and might neglect their self-care. Economic burden. Insulin, glucose monitoring device, and other diabetes management tools can be costly. And not all insurance plans cover all diabetics care necessities, leading to out-of-pocket expenses. The other challenges is medical condition. The risk of blood sugar dropping too low, as we call hypoglycemia, which can be life-threatening. And also, they have to manual measurement can lead to over or under dosing. And if they don't manage properly, diabetes can lead to complications like disease, neuropathy, retinopathy, and cardiovascular disease. Misunderstanding or misconception about diabetes can lead to stigmatization for the patient. Navigating social situation like parties or gathering where food and drink are involved can be changing. Oops. We Okay. How about the nurse? Nurse play a pivotal role in the care of patient with diabetes. Their responsibility are multifaceted, ranging from the clinical care to patient education, advocacy, and also research. Nurse should do assessment, checking for complication of diabetes, including neuropathy, sign of poor circulation, vision issue, or skin infection. Nurse also assess blood glucose monitoring regularly and also understanding the patient dietary habit, physical activity level, and other lifestyle factors. Checking the patient current medication, understanding their patient regimen, and ensuring there are no potential interaction or miss doses. The nurse also should educate the patient, educating patient about the pathophysiology of diabetes, teaching patient how to check their blood glucose level and what the result mean, and explaining how diabetes medication work, potential side effect, and the importance of adherence. Nurse also providing guidance on carbohydrate counting, meal planning, and the importance of balanced diet. Emphasizing the role of physical activity in managing blood sugar and overall health. And also teaching sign and symptom and how to treat low blood sugar episode. In the clinical care setting, a nurse administering insulin or other diabetes medication if patient is in hospital or clinical setting, and assisting with insulin pump setting and troubleshooting if the patient use an insulin pump, regular food checks and education on proper food care to prevent complication, recognizing and treating both acute and chronic complication like neuropathy or retinopathy. Not also must support their psychosocial patient. Nurse recognizing sign of diabetes burnout, depression, or anxiety, and referring to appropriate resource of or professional. Recommending diabetes support group on the educational classes. And for the role of the care coordination, nurse coordinating care with other healthcare professional such as dietitian, endocrinologist, podiatric, and also ophthalmologist. Nurse also ensuring a smooth transition if patient is moving from one setting to another, like from hospital back to their home, and ensuring patients have follow-up appointments and the necessary resourcing for continued care. Sorry. And health promotion, nurse participating in community screening for diabetes or risk factor. And nurse also engage in continuing learning to stay updated on the latest research, medication, and technologies related to diabetes. Insulin therapy is central to the treatment of type 1 diabetes. And it's also used in many cases of type 2 diabetes, especially when other treatment fail to achieve desired blood sugar control. What is the insulin? Insulin is a hormone produced by beta cell in the islet of Langerhans within the pancreas. It helps cells take in glucose from the bloodstream to use for the energy. When the body doesn't produce enough insulin or doesn't use it effectively, glucose remain in the blood, leading to high blood sugar level. Type of insulin type are categorized based on the function, molecular structure, and how quickly they start to work and how long their effect lasts. There are two types of insulin based of the function, which are basal insulin and prandial insulin. What is the basal insulin? Basal insulin is the insulin our body needs even when we haven't eaten. It's like the baseline or background amount of insulin that's always present in the blood. Basal insulin maintain glucose level in the range between meals and overnights. In essence, it keeps blood sugar stable when you are not factoring in the influence of food or exercise. Prandial insulin. Prandial insulin is the insulin the body needs to handle the sudden influx of glucose into the bloodstream after eating carbohydrate. Prandial insulin used to control the spike in blood glucose level after meals. And for people with diabetes who cannot produce enough of their own insulin, injecting prandial insulin can mimic the natural post-meal insulin response of non-diabetic person. And we know that type of insulin molecular structure. There are human insulin, insulin analog, and biosimilar insulin. Human insulin is the name given to synthetic insulin that identical in structure to the insulin naturally produced by human. And insulin analog are modified forms of human insulin. They have small chains in their amino acid structure, which alter pharmacokinetic properties like the onset, peak, and duration of their action. And biosimilar insulin are versions of approved insulin product that are brought to the market once the original product patent expire. They are, we call generic in traditional sense because insulin are complex molecule produced in living cell, making them biologic. And there are type of insulin based on its onset, how soon they start to work, and when their glucose lowering effect is stronger, and the duration or how long they last before they wear off. We know there are rapid acting insulin, short acting, intermediate acting, long acting insulin, and ultra acting insulin. Rapid insulin or rapid acting insulin begin to work shortly after injection, start working in about 15 minutes, and peak in about 1 hour. And the insulin continue to work for 2 to 4 hours. And short-acting insulin begin working within 30 minutes after injection and peak between 2 to 3 hours and continue to work for 3 to 6 hours. And the long-acting insulin start working in about 1 to 2 hours and peak in 4 to 12 hours and continue work for 12 to 18 hours. And for long-acting insulin, begin working after several hours after injection and last about 24 hours or longer. And ultra long-acting insulin provides steady insulin level for over 24 hours with once daily injection. And premic insulin is a combination of rapid or short-acting insulin with intermediate acting insulin. So this is the graphic of insulin action profile. You can see how soon its insulins start to work when their glucose lowering effect is strongest and how long they last before they wear off. There are some indication for administration of insulin. You know that the type 1 diabetes mellitus, insulin is essential for all individuals with type 1 diabetes because their body produces little or no insulin. And type 2 diabetes mellitus, especially as the disease progress or if blood glucose level are not adequately controlled with other medication. And for the gestational diabetes, some women may need insulin to protect both the mother and the baby. And the other indication is diabetic ketoacidosis. Diabetic ketoacidosis is a serious complication of diabetes where high blood glucose level lead to the build-up of acid, or we call ketone, in the blood stream. And immediate insulin therapy is required to lower blood glucose level and reverse the acidosis. And the other hyperglycemic hyperosmolar state This is the condition, a severe condition primarily seen in type 2 diabetes with extremely high blood glucose level without significant ketosis. Insulin is required to bring down to elevate glucose level. Stress or surgery also need the insulin because condition of stress or severe illness, blood glucose level can rise and sometimes necessitate temporary insulin therapy even in people without a prior diagnosis of diabetes. Insulin may be required temporarily during or after surgery or certain medical procedure, especially if oral medication are temporarily stopped. And the other indication is the total parenteral nutrition. Total parenteral nutrition is a method of delivering nutrition directly into the bloodstream. It used for patients who cannot or shouldn't receive feeding orally or enterally. TPN solution typically contain a significant amount of dextrose, which can raise blood sugar level. So patients who are receiving TPN, especially those who are not diabetic, might develop hyperglycemia due to the high glucose load. And insulin can be added to the TPN solution or administered separately to control blood sugar level. Conditions like chronic pancreatitis, cystic fibrotic, or hematochromatosis, or pancreatomy can damage the pancreas and impair insulin production. So people with this condition might need insulin. The other indication is steroid-induced hyperglycemia. Some individuals receiving steroid therapy may experience high blood sugar level, which can sometimes require insulin for control. Sometimes insulin is used in a hospital setting for specific non-diabetic condition. For example, it may be used alongside glucose in potassium level. In potassium lowering protocol for hyperkalemia. And this is the challenge in insulin therapy. Insulin therapy is essential and life-saving treatment for people with type 1 diabetes and many type 2 diabetes. However, there are various associated with its use, both for patient and healthcare provider. Here are some of the main challenges. The first one, we know that hypoglycemia is one of the most common and fear complication of insulin therapy because the brain only get energy from the glucose. And the other challenge is weight gain. Insulin can lead to the weight gain, which can be significant concern for many individuals, especially since excess weight gain can worsen insulin resistance. Complex regimen in insulin therapy refer to the multifaceted and sometimes intricate dosing schedule and management protocols that patient must follow to achieve optimal blood glucose control. Managing diabetes with insulin isn't as simple as just taking a set amount of insulin every day. Many patients, especially those with type 1 diabetes, are on regimen that require injection multi-time a day. injection-related issue, what we call lipodystrophy. Repeated injection in the same site can cause either lipoatrophy or lipohypertrophy. This is the accumulation of fat tissue. Rotating injection site can help mitigate this. Insulin, especially newer formulation, can be expensive. This can be a barrier to access for many patients, leading to inadequate control or dangerous rationing of insulin doses. The constant management of blood sugar level, fear of hypoglycemia, and the stigma associated with taking injection in public places can contribute to stress, anxiety, and even depression for the patient. And the other challenge is life adjustment. Like I said before, patients often need to adjust their insulin doses based on their activity level, diet, and other factors. This requires a deep understanding of one's body, the effect of insulin, and can be daunting for many. Needle phobia or the discomfort from injection can deter some individual from adhering to their insulin regimen. Multiple daily injection or the need to wear and manage an insulin pump can be inconvenient and disrupt daily activity for patient. Insulin also need to be stored under specific condition, usually refrigerated until open, then at room temperature. Traveling or being in places without the right storage can poses this challenge. And social stigma, this is also I already talked before. And this is about the importance of innovative care solution. The challenges faced by diabetic patients emphasize the critical need for innovative care solution. How the diabetic patient can improve their quality of life. Device like continuous glucose monitoring can reduce the need for multiple daily finger prick, and smart insulin pen can track insulin dose, reducing dosage error. And also, we also need diabetic patient reduce complication. Better management tool can ensure blood glucose level are kept within a tighter range, reducing the rate of long-term complication. Also, integration with the technology like smartphone apps can track and analyze blood sugar level, insulin dose, and carbohydrate intake. The artificial pancreas or closed-loop system can automatically adjust insulin dose based on the real-time blood glucose data and drastically reducing the burden of daily management. And then psychological benefit, easier management tool and less daily burden can reduce the feeling of burnout and anxiety and depression. Beyond management, innovative research is delving into potential cures like islet transplantation and stem cell therapies. So, this is the main topic today. is the artificial pancreas. Sorry, what the artificial pancreas? Artificial pancreas is not an actual pancreas. The artificial pancreas is an external device or system of device that mimic the glucose regulating function of healthy pancreas. The artificial pancreas operate in a closed loop system that consists of three components, such as continuous glucose monitoring device, dosing algorithm, and an infusion pump. Continuous glucose monitoring. This device measures glucose level in the interstitial fluid continuously through the days and night and provide real-time feedback on the blood sugar level and trend. And control algorithm. This is essential, the brain of the artificial pancreas. The algorithm take the data from the continuous glucose monitoring, process it, and then instruct the insulin pump on how much insulin to deliver and when. And the insulin pump, this is the device that continuously delivers insulin into the body. Insulin pumps can replace the need for multiple daily injection by delivering precise doses of rapid-acting insulin to cover carbohydrate intake and maintain basal metabolic needs. And how the artificial pancreas work? The primary aim of artificial pancreas is to automate the delivery insulin in response to fluctuating blood glucose level, reducing the burden on individuals with diabetes to constantly monitor and adjust their insulin doses. The continuous glucose monitoring continuously measure glucose level in the interstitial fluid through a small sensor inserted under the skin. And the data from the CGM is then sent wirelessly to the insulin pump. And the insulin and the system use computer algorithm to interpolate the glucose data from the CGM, and based on the current glucose level, its range of change, and other factors, the algorithm determine how much insulin the user needs. And the insulin pump deliver the required insulin dose subcutaneously as dictated by the algorithm decision. Most systems use rapid-acting insulin. And beside this device, users still need to input information like meals, carbohydrate counting, or exercise to help the system anticipate and respond to the potential change in the blood sugar. So, what is the benefit of artificial pancreas? One of the main advantages is the potential for improved blood glucose control. By constantly adjust insulin delivery based on a real-time glucose reading, the system can reduce the occurrence of both hyperglycemia and hypoglycemia. And then, of course, reduce risk of complication, improve glycemic control, the risks of long-term diabetes complications such as neuropathy, retinopathy, kidney disease, and cardiovascular disease, because the patient can control their blood glucose. And then improve quality of time because nighttime hypoglycemia is significant concern, especially for individuals who might not recognize the symptom while sleep. And artificial pancreas can actively monitor and adjust delivery overnight, reducing the risk of severe low blood sugar event. And flexibility in lifestyle, with more consistent glucose level and fewer demand for manual adjustment, individual may find it easier to engage in a range of activity, from exercise to dining out with less worry. And then reduce fear and anxiety, the fear of hypoglycemia, in particular, it can be paralyzing for some individual with diabetes, knowing there is a system in place to prevent extreme high and low can over peace of mind patient. This is also increase sleep quality, like I said before, since the system can adjust insulin delivery overnight. Individual and their loved one can rest more easily without the constant worry of the nighttime glucose fluctuation. And the other, for the data integration, many artificial pancreas system integrate with the smartphone application or data digital tools, allowing user and their healthcare provider to analyze data, track trend, and make informed decision about care. And this is the kind of artificial pancreas from the many manufacturer. There are Medtronic Minimed. They have the newest generation without need calibration. And from the EcoCheck and also from the Abbott and the others. And this is the evidence-based that artificial pancreas can improve that quality of life patient with the type 1 diabetes. This is also the evidence-based with the from the type 2 diabetes. And a challenge and consideration using the artificial pancreas. The challenge is the cost accessibility. We know that artificial pancreas is costly, and also the patient can over reliance because of they think that there are devices that help them, so they sometimes doesn't control their habit, diet, and also the activity. And also safety concern, technical issue, maybe there is a troubleshooting in the device, and also physical concern, maybe the patient cannot comfort with the some device are stick in their body, and also psychological factor, they overthinking the devices, And limitation of extreme people with the artificial pancreas need to limitate it of their activation, especially in the extreme activity. But in the daily activity is not problem at all. And the other device need for calibration. But in the newest artificial pancreas, they are not need more calibration. And for the device still need the calibration, doesn't eliminate need for finger stick checks, because for the calibration, the patient need to check their blood glucose from the finger prick. So the role of the nurses and in the role of nurses in redefining, promoting, and implementation of the artificial pancreas. Nurses, particularly those specializing in diabetes care, play a multifaceted and vital role in the journey of the artificial pancreas from research to routine clinical use. Their roles can be, you can see from the slide, education, patient education. Nurse often take the lead in educating patient about the new technology, and they break down complex concept about the artificial pancreas into understandable term for patient and their family, facilitating informed decision. And there's also participation in research. Many nurses are involved in clinical research, including trial for artificial pancreas system. They may help design protocol, obtain informed consent, monitor patient, and collect analyze data. Monitor and follow up. Nurse should regular check up, often coordinate and conduct regular follow up appointment to ensure the artificial pancreas is working correctly and efficiently. And modern artificial pancreas system provide a wealth of data. Nurse, alongside other members for the healthcare team, can review this data to determine if any adjustment in setting or patient behavior are needed.
Yeah, Dr. Debbie, my apologies to interrupt. The committee said you have 5 more minutes to complete the presentation. Thank you very much.
Yeah. One more slide. Okay. For feedback for manufacturer, nurse gather feedback from patient about the device, usability, comfort, and other glitch or problems. And this feedback can be crucial for manufacturer in refining their product. And also for the emergency management, hypoglycemia and hyperglycemia, if the artificial pancreas system fail or malfunction, it can lead to extreme glucose fluctuation, and nurses are to recognize and treat this emergency situation, whether it's administrating glucose or providing acting insulin. And for the promotion and awareness through seminar, workshop, and other platform, nurses can raise awareness about the benefit of the artificial pancreas, reaching out to both the healthcare community and the public. And as a frontline caregiver, nurses can also educate fellow healthcare professional about the benefit, limitation, and practical aspect of using an artificial pancreas. So, conclusion, managing diabetes can be challenging, even with careful monitoring and use of insulin. It is not always easy to keep blood sugar level normal. And artificial pancreas has the potential to bring peace of mind to more than 100 million diabetes patients in the world who need insulin for their therapy. A closed-loop insulin delivery system or artificial pancreas could significantly decrease the patient burden of managing diabetes, risk of hypoglycemia, and decrease long-term complication of hyperglycemia. By actively redefining insulin therapy and promoting the groundbreaking innovation of the artificial pancreas, nurses are to the front of a transformative approach to diabetes care. Nurses ensure the progress is not just about technological advancement, but more importantly about to be a better human. Thank you. That's all my presentation.
Okay, thank you very much, Dr. Debbie. Can you please give a big applause for Dr. Debbie? Okay, we're here gathering in an auditorium with hundreds of nursing students, Dr. Debbie. They're clapping for your presentation, and they're following your presentation. For sure. Okay, right. So that's a very fruitful presentation, as I said, from basic theory to practical applications. And it seems like we've got one question from nursing student, Dr. Debbie, and he's requesting to speak to you to deliver the question, if you don't mind to. Yeah, go ahead.
Sure.
Thank you. Thank you for the opportunity. My name is Agung Salim. I'm a nursing student at the Gorontalo Ministry of Health Polytechnic. Referring to your material, administration of insulin can give to mother with gestational diabetes. My question is, does it have a danger side effect to mother or for the baby? Thank you.
So the question addresses side effect to the baby. Over to you.
Yeah. Okay. Okay. It's like what I said before, that gestational diabetes need the insulin for the treatment. The insulin for pregnant woman, of course, for the prevent the hyperglycemia that can cause complication such as hypertension. Yes, that I said before, that it's very dangerous for the mother. So the doctor also in giving insulin predict the dose who safe for the baby. Yeah, and so far there is no data. There are the side effect for the baby from the gestational diabetes. Yeah, like side effect insulin in common, such as hypoglycemia. This is the side effect, the common side effect from the insulin. So this is need more attention for the administrating insulin. I think that's my answer?
Yeah, thank you very much, Dr. Debbie. Well, I guess we have some more questions, but it seems like we're running out of time. And on behalf of the committee, we would like to say thank you very much, Dr. Debbie, for contributing to this conference. And for the last thing, the committee would like to present you a certificate of appreciation that should appear on the screen. Yeah.
Thank you.
Okay, right. Once again, thank you very much on behalf of the committee, Dr. Debbie, for your participation and contribution to this conference. We wish to see you again in the next opportunity. Thank you and have a good
Bye-bye.
one. Bye.
Bye.
Okay, ladies and gentlemen, as we have just concluded the first session, we will have a break for now, but please be advised that we're going to resume this conference at 1 p.m. Yeah, at 1 p.m. Western Indonesian time. Okay, once again, we're going to resume this conference at 1 p.m. Western Indonesian time. Thank you, and we'll see you soon. Dorang belum tahu itu dong, Mbak.
Check sound.
Distinguished guests, ladies and gentlemen, now we are going to the session 2. The session 2 will be moderated by Mrs. Fariatul Falah, Escape Nurse MCAP. To Mrs. Fariatul Falah, Escape Nurse MCAP, the floor is yours.
Yes, thank you very much for the Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon, all of the conference participants. I hope all of the participants feel highly excited to involve in our second plenary session. And my name is Fahriatul Farah. You can call me Ria. I'm now working as nursing lecturer at Nursing Diploma Program of Gorontalo Health Polytechnic. As Master of Ceremony said before, I will lead the second plenary session for today. And referring for our theme today, the second plenary session will be focusing on management of cardiovascular disease. Our plenary session, like before, will be divided into two sessions. First session will be presentation session with a time limit 45 minutes, and then will be continued to discussion session for 15 minutes. Ladies and gentlemen, we all know that cardiovascular disease already becoming one of degenerative disease with highest incidence nationally and globally. So that all of health workers here are required to be able to provide update intervention. But the fact in Indonesia especially, some nurse and health worker focus only to the acute phase care for cardiovascular disease and pay less attention to care rehabilitation process. And to discuss in depth how important the cardiovascular rehabilitation is and how far the role of nurse in it, we invited the expert speaker for today, Dr. Lee Wan Ling from University of Malaya. But before the presentation, let me read the curriculum vitae of her. You can see on the screen, Dr. Lee Wan Ling, PhD SRN. Now he holds a senior lecturer position in Department of Nursing Science, Faculty of Medicine, University of Malaya. She was a practicing clinical nurse in the coronary ward in 1992, appointed as a nurse educator at the College of Nursing, University of Malaya. And after obtaining her PhD in 2018, she is actively involved in research activities with some interest in mobile health, technology in education, and aged care, especially in long-term facilities, cardiac rehabilitation, and coronary care, cross-cultural adaptation and validation of questionnaire, health literacy, and non-communicable disease. She also leads in many interdisciplinary programs to develop caregiving for older people in collaboration with aged care industry. She also expanding the development of electronic activity tracking system called UMFit with a team of researcher working on project entitled AI-enabled application for personalization and monitoring of fitness among cardiac rehabilitation patients. So it is very exciting to read her curriculum vitae and very inspiring. I want to greet our speaker, Dr. Lee Wan Ling. Good afternoon.
Good afternoon.
Yes, it's very an honor to us for having you involved in our online conference for today.
Thank you for having me.
Yes, you're welcome, Dr. Lee Wan Ling. So I want to please you to beginning your presentation for today.
Okay.
So time is yours.
Okay, thank you very much.
Yes, you're welcome.
So let me share, right? So are you able to see the screen? Is my slide being shared?
Yes.
Hear my voice?
Yes.
Okay, excellent. Okay, thank you very much, Ibu Fariato, for your kind introduction.
Yes.
Thank you for having me again. Salam sejahtera to rectors, esteemed professor, academicians, beloved students, ladies and gentlemen. Yeah. Firstly, before I begin, I would like to take this opportunity to congratulate the nursing departments of Polytechnic Kementerian Kesihatan Gorontalo for organizing this first international conference on nursing updates and healthcare. And then the team is really timely indeed because we do battling with a lot of diseases, especially degenerative diseases, and how we can play our role to transform the healthcare system for the betterment of the patient's well-being. So what I would do within 45 minutes, that I will begin with overview of the cardiac rehabilitation. I know some of the audience might not be from the cardiac background, but as I share about cardiac rehabilitation, it also can apply to rehabilitations nursing. So you can see it as using the context of cardiac rehabilitation and see how it can be applied in the area or in the field of rehabilitation nursing. And these are the area that is in need indeed, because we need to help patients after they have some kind of adverse event, be it having a stroke or even motor vehicle accidents, or fall very ill, sick. They need to have some form of rehabilitation so that they can regain back to their normal life as much as possible. So I'm going to give overview of cardiac rehabilitation, but also I would like to share some lights how far we have progressed in terms of cardiovascular disease management. Do we really need to have some transformation? Are there any gaps? How bad is the gap? Are there gaps? And then maybe we can have an exchange or opinion to talk about innovation in cardiac rehabilitation services. You will see there are a lot of ongoing work is coming in, right? Especially in this era, when our world become digitalized, we are living in a digital era. And lastly, I will give more emphasis about our role, being a nurses. How can we drive innovations or transformations of rehabilitation using cardiac rehabilitation as an example to illustrate it? Okay, so let's begin. So what is cardiac rehabilitation? You will see that cardiac rehabilitation is basically referring to a multi-component intervention. And it is not just a single intervention, but it's a multi-component. You need to have all this. You cannot have one and not the other, because you will not be able to achieve effectiveness of a cardiac rehabilitation if you just only have few components. So you will see from here, right? So the ultimate cardiac rehabilitation is to assist our patient to have some form of heart behavior change by giving them adequate patient education to empower them. So what they need to know in the context of cardiac patient would be they need to able to do exercise training, because exercise will increase their capacity, the cardiovascular fitness, which is important. They need to regain it back. And physical activities, so they will not be going back to their sedentary life. And need to have a health education, particular in terms of lifestyle risk factor. If they are smoking, we need to deal with the smoking issue. If the person is hypertension, we need to talk about how they can control their blood pressure. And if the person is diabetic or they have high cholesterol, how do they go about controlling? Okay, because all these are risk factors. You need to assist them to identify the risk factors, educate them, empower them, how they can bring this risk factor under control. Then you also need to talk about putting them on optimal protections with medications. We call it cardioprotective therapies, meaning that we're using, patient will be on, the regimes of medication that aim to protect their heart and from developing complication. And definitely, it is also well known after a person's have a severe adverse cardiovascular event like stroke or heart attack, they will have a lot of issues regarding about their psychological aspects. Depression is kind of common among these populations of patients. And then they have also financial issue, a lot of them, they are at a productive age, they need to work, they're sexually active. So there are a lot of issues that can trouble them. So how we give that support. So psychosocial health is also important. And definitely some of them might need to go for some form of intervention, like they need to go for surgery or percutaneous coronary interventions, putting on stents or angioplasties or balloon. And these are all the challenges, the journeys, the difficult journeys patients has to go through after they have that kind of major events. Therefore, cardiac rehabilitation is actually required. It's essential. And then it has to be personalized to individual needs because not one patient is the same. Now, the cardiac rehabilitation has been divided into 3 phases. Phase 1 begin, in fact, at the very first day of admission to the ward, right? What happened here is basically we want to mobilize them as soon as they're stable. We do not want them to just lay down on the bed. Okay, we want to mobilize, have range of motions. Now, this is a phase is very important to start with. Then after that, when they discharge, then they will be put on the phase 2 cardiac rehabilitation as an outpatient, where they have a supervised exercise on top of the other component as well. Okay, and then lastly, they will be on the maintenance, the phase 3, that will be sort of like their own lifelong maintenance, because this cardiovascular disease is a form of lifestyle disease. You have to have a change of lifestyle, and it's not easy, to have a change of lifestyle. You're not just changing your diet. Sometimes a certain patient have to do a lot of sacrifice, a lot of changes, change diet, have to exercise, stop smoking, control blood pressure. That's a lot to ask for a person, in just in one period of their lifetime. Now, how is it important? Definitely it is important because there are ample of literatures, ample of study has been conducted to support that cardiac rehabilitations. It definitely will be able to reduce cardiac mortality by 31% or cause mortality by 27%. It is actually a class 1A recommendation, meaning that it is highly, highly recommended. It's like an essential. In other words, all patients after they have a major adverse cardiac event like stroke or heart attack, they should be putting on a cardiac rehabilitation because it is an essential form of therapy to have to prevent secondary event, right? So the mortality or the morbidity will be reduced when the person who undergo cardiac rehabilitation has been found to have a better general health and well-being, right? They feel stronger, they feel better, feeling better, their well-being feel better, their heart is stronger, and then their cholesterol is well controlled, their heart health is improving, okay? And then they're reducing all the complications, reducing heart failures incidents, reducing hospital admission, chest pain, and etc. So there's a lot of benefits in cardiac rehabilitation. However, do we really need to transform cardiovascular care? So when you say about transformation, if you look at the dictionary, it means a major change. a major change or significant change can happen in very fast and happen to be gradual. But I believe that cardiovascular care, the transformation would be slowly and gradual. Actually, it has been started, so we are just continue the journey. So I will share with you what are the journey that we are on it, so that if you will be interested, you can come and join in and play your role, okay, to improve the cardiovascular care in your country and the global as a whole. So how far do we progress? How much have we progressed in achieving the disease management of cardiovascular disease? Is it enough, or do we need to do more? You can see that from the statistic, after many years, fortunately, cardiovascular disease still the number one cause of death. Not to say we didn't progress at all. Yeah, we did. Yeah, we have. There's a lot of development. You know, the surgery have been advanced, the medication has been advanced, and the interventional cardiology advanced. There are many advancement in the treatment of patients with cardiovascular disease, and yet it's still a number one cause of death. So there is still an area that we need to do more, because there are more than 75% of those cardiovascular death took place in the low and middle income countries. That include my countries too. And in our region, Southeast Asia region, we are in the area of a low to middle income country. And we have a statistic to show that here, there is a huge disparity between those high income country and low income country, right? So disease burden in the low middle income country is high. Now in the developed countries, in the high income countries, you will see the one in the green color. They have significantly reduced mortality and morbidity from cardiovascular disease. But in the middle income country, there's a lot more that we can do, right? So there is an issue that unequal access to healthcare services. So we need to find how can we transform cardiovascular care that everyone in four corners of the world, in all countries, have an equal access to an effective treatment, including cardiac rehabilitation. And you can see from here, showing that the number of cardiac rehabilitation program per country. And the one that in green is the developed country, high income country. They have a lot of cardiac rehabilitation services available. But however, in our countries, you can see around here, okay, it's suboptimal. There is not enough cardiac rehabilitation services to serve our people. Now, when the patients admitted to the ward, typically you will see that it has to be referred to the cardiac rehabilitations. It has to be referred. And then who are the person who's doing the referral? And then when they refer to the cardiac rehabilitation team, it has a team on its own. The patient will be assessed, and then we will develop a kind of plan. And then they will be enrolled in the cardiac rehabilitation services. And there is a program they have to undergo. Right. Upon completion of the program, we will do a final check, see whether they have improved, and then discharge from the phase 2. Then they will move on their own to the phase 3. However, despite cardiac rehabilitation has been around for many years, way back in 1950s, you will still find the referral rate, the number of patients being referred, the number of patients enrolled in the cardiac rehabilitation services, and the number of patients actually follow the program, comply to the program, and the number of patients that actually completed the whole program, still low, still suboptimal. As you can see from here, it goes by 23 actually sessions, and then
1724, right? By the end of the whole full 36 session, that is a full course, full course. It's only left 8. So there's a lot of dropout. Okay? Even though we managed to enroll them in, there is a lot of dropout. So why is it so? Okay? That is something that we have to explore and find how can we transform the cardiac rehabilitation's delivery models to maintain a good completion rate. And besides that, there is also another issue regarding about cardiac rehabilitation participation. You will find that more male enroll in a cardiac rehabilitation compared to female, more male. But you know that actually female really benefit from cardiac rehabilitation because most of the time when the female patients have a heart attack, they are usually at the older age. So they are more likely to have complication. So they do need a cardiac rehabilitation. However, you will find less ladies has been sort of like referred to, encouraged to enroll into the cardiac rehabilitations for many reasons. We will talk about the reasons in the subsequent slide. Another group of patients that seems to have low participation in cardiac rehabilitation will be those with low socio-economic status, those with low income, low education, older age, partly because maybe they cannot afford or there will be logistic issue, transportation issue. And sometimes what mistake we have done in the past that we have just one program and we hope that it fits, one size fits all. We thought that this program will work for both male as well as female patients. And you will see that from the study that we found that not only women has low participation rate, they have low referral, low enrollment, low completion. The outcome when they join a cardiac rehabilitation, the outcome also different from the men. Okay? They're different in the sense that the number of them really completed exercise training doesn't seem to on par with the male patient. So, in other words, it's time for us to look a unique need of a woman when they join a cardiac rehabilitation. Now, whatever that we plan for a male patient might not work that well for women because of maybe cultural aspects, personal preference. Okay, being a woman, we have our own unique preference compared to men. Okay, so these are the areas that we can explore. Okay, what else? These barriers, why after so many years, after so many decades, utilization of cardiac rehabilitation is still very low because we know cardiac rehabilitation is essential. It has a lot of benefit, but not many patients really utilize it. After so many years. So there are actually legitimate barriers why hinder patient from participating in a cardiac rehabilitation. So it is our role to find how can we overcome these barriers. So what are the barriers? So number one will be things like practical, especially if you ask your patient to come to a hospital or medical center, to a cardiac rehabilitation center. They have to make time, they have to find transport, right? They have to, if they drive, there's a parking issues, right? And then there's a lot of issue. There's a lot of logistic issue. It's not so easy. Also, if a person do not drive, especially ladies, a housewife, they don't drive. They are very much reliant on the children or the husband. Yeah, right. That's one thing. There's also maybe from the patient's factor. They don't say it's important. Okay? Maybe they don't understand whatever that is being delivered to them, or they have low motivations, or maybe they don't have time. So whatever personal reasons they have can be a barriers for them to benefit from cardiac rehabilitations. And not only that, what is most often that we do not look into would be the way we give the service, the system, and the way how efficient are we refer patient. to a cardiac rehabilitation services. It's also, it doesn't come free. How can we help patients to afford cardiac rehabilitation service, right? That is the system itself that we need to look into. And here are the slides to tell you that way back in the 50s, the cardiac rehabilitations has been actually started, in a hospital, right? Okay, from the traditionals, very conservative, very minimal exercise. Then we decided that, we did the studies, it must be a bit more, exercise is actually good. And you'll find that we mobilize our patient much earlier. Yeah, we make patients exercise, right? Not just rest in bed in those days. And then finally, in the year 2000, when we discover all this logistic issue, the barriers, then we have a home-based cardiac rehabilitation. So meaning certain selected patients, those low risk, moderate risk, we can allow them to have cardiac rehabilitation from the comfort on their own home. Right? Then after that, you'll find that there's an issue, when you're at home, when patient at home, the motivations will be low, the compliance will be low. So what happened now is there is more towards a combination, hybrid, meaning that there will be certain days patient need to come to the center so that we can sort of assess them, encourage them, and the remaining will be at home. So we have that combination. So what is the combination? It would differ from center to center. Okay. Now, despite that, we have so many advancements in surgery, interventional cardiologies, medicines. The cardiac rehabilitation program is still kind of static in a way that they do not change that much, the program itself. However, sometimes, bad things can bring good things. Ada hikmah di sebaliknya, they say. So when the COVID-19 pandemic hit us, when there's a lockdowns in many, many countries, and there's a disruptions of many sphere of life, and people change, healthcare system change, forced to change. These are called abrupt transformation. Everybody changed. Cardiac rehabilitation was actually put on stop during that time, even in my place, so put on stop. So these patients couldn't come to the medical center to attend cardiac rehabilitation. And then thank God that we have internet technology. Therefore, healthcare professionals who are initially kind of hesitate to use technology, as part of their patient care. So they started to have, telemedicines. They started to use internet to deliver cardiac rehabilitation. So I would say that, COVID-19 is the catalyst that has been transformed hybrid cardiac rehabilitation. What happened here is that the hybrid cardiac rehabilitation has been technology driven. There's a digitalization of hybrid cardiac rehabilitation. People are more creative in how to make the delivery models more effective and more efficient. People has looked into one-to-one visit virtually. People also conduct group virtually. They also have some program that have asynchronous exercise, meaning that you give a program to the patients. You don't need to be live, have live session with them. They can do it on their own, right? Then some of it will come out, hey, we need to have some form of remote monitoring, meaning that we do not let them completely out of our radar. So we have some form of digital devices to have that form of remote monitoring. And you can see that, ever since, that's one slide is missing. So you can see that the digital evolutions has brought transformation of cardiac rehabilitation services, actually. I remember in those days, we used to wear the pedometers, we just put in there and it would detect, our body movement to sort of estimate our steps. And then we give patients the pamphlets, for them to read. and then they can do their cardiac rehabilitations at home. And then they will come, they will ask them, okay, come to our center, but a lot of time that there's a lot of issue, they couldn't come. So we have a lot of challenges, getting patients to come to the center to have an effective hybrid cardiac rehabilitation. Then come smartphone technology. Now the smartphone technology now has evolved from the bulky one. It's become thinner, become more sophisticated. I remember last time, the runner used to strap the smartphone on the arms and try to run. The phone will be like a pedometer to capture their steps, right? And then now, you will see how the smartphone has evolved. You can have a lot of personalized program in it. And then what really is sort of exciting will be the wearable technology that has been evolved. Now we have wearable technology like the one I'm wearing, okay? Sync to my phone, and it will capture my heart rate, it capture my oxygen saturation. So it's a whole lot of things that enable the patient to monitor themselves, because when a patient monitor themselves, that when they see all these parameters, it sort of incentivize, motivate them. Oh, I'm doing well. Well, I'm achieving my heart rate, my oxygen saturation maintaining good. It's giving them form of motivation, but at the same time, it also connect. Now, if you have a system, then you have a cloud technology, you'll be able to get the patient data, extract the patient's data into your own platform. You'll be able to monitor in the center and the patient's progress. If a patient's heart rate go beyond, it will trigger alarm. You can send reminders. So all this smartphone and wearable technology has allowed not only patients to do self-monitoring, but also allow healthcare professionals like us to do remote monitoring. And they don't need to come, but we know that they are exercising within that prescribed limit. And now it's coming with the AI technology, and it's a new buzzword. Everybody talk about AI technology because we will see that the exciting things that AI technology can do. However, it depends on the data. These are evolving technologies. There's still a lot of issues surrounding it. Even I myself in the journey of learning about it. But what we hope to get from, what we hope to harness from AI technology is that it will be able to reduce intensity of the manpower, meaning that it will be, for instance, it can be automatically detect something wrong with your patients, right? And then it will send you an alarm. That's one example. Or it can be automatically prescribed. You have a patient, then you put in data, the machine will be smart enough to prescribe exercise regime that suits the patient. That would be a wonderful, exciting development. Yeah, it's one thing we are looking into that. And this is just all the digital tools as is now is going on. And the digital tools are there. We do not need to create new ones. It's there. So how can we make use of the digital tool available out there? Now, having said that, what I would say that these digital tools cannot replace man. It cannot replace man-to-man, mankind interaction because it only become a tool that enable healthcare professionals to increase engagement with the patients. So meaning that a healthcare professional still need to have that kind of connection to the patients. When it comes to planning, together with the patients, to have the interactions, to give them knowledge. And to a certain extent, you still need a human. I don't really believe that the machine will completely eliminate human interactions. Right? I'm not sure. Maybe in another decades or so, but at the moment, you will find our patient, no matter what technology they're using, they still want to meet us, healthcare professional, to have that human conversation. Yeah. So here is basically to tell you that if you have a home-based cardiac rehabilitation hybrid and you want to sort of digitalize your cardiac rehabilitation, there are four main aspects that is required based on past experience of researcher who is doing this. Number one, they say it would be there must be some form of remote monitoring, streamline, and whatever tools you're using, it will be allowed a healthcare professional to monitor. Otherwise, you will not know whether your patient is doing well, whether they exercise beyond the limit or below the prescribed heart rate targets. The next, there must be a way that the healthcare professional sort of communicate, right, through portals, text messaging, phones, right. Then there must be a usable patient interface, and then lastly, what happened is, at the moment, it's still safe for patients with low and high risk. We have not gone to that. I think our technology has not been mature enough to be able to serve patients with high risk, because high risk definitely need a very close monitoring at the cardiac rehab centers. So but those who's low and moderate risk, we can consider hybrid or even home-based with the help of technology. Right. Okay. I think I still have time. Having given you the overview of all those things is going on, right, and it's still going on, right? What are the roles as us being the nurses in transforming the cardiac rehabilitation services? How we can make it better? You have here the barriers, you have here the challenges. How can we, our role, make it better? Well, my take will be number one, to transform cardiac rehabilitation service, you have to look for the beginning point. At the very beginning point, when the patient's admitted, okay, after some kind of adverse event, then there must be a mechanism to refer. Okay? Because if you don't refer them there, you will find that most of them will not, we will lose them from the system. So we will think about, we can have some form of automation. A lot of hospital has this electronic information system, like my hospital, University Malay Medical Center. It's all been sort of like, we use a lot of computers. So patients come in, everything, the digitalizations of the hospital system is on the rise. And then if we can have automation referral, that would be great. Because humans sometimes forgot about it. The doctors are busy, the nurses are busy, and then they forgot, oh, that patient needs a cardiac rehabilitation, a referral. So if you have some kind of referral, specific, okay, the system will just sort of send message, through the team. And there is a patient that you need to see, and that will be reduce the human error, okay, or the human limitation. And many studies has found that, patient participation in the cardiac rehabilitation are really, really affected or influenced by how strong the endorsement by cardiac physicians, the cardiologists, or the cardiac surgeons. Now, if the cardiologists, especially the cardiologists and the cardiac surgeons, they have their own, if they don't sort of endorse their peers, the cardiac physicians, the patient might not see that it is important for them to take part in cardiac rehabilitation. So the endorsement is very important, not just the cardiac physicians alone. Because based on my experience, our cardiac physicians will go to the ward and then talk to the patients. The patient will still, okay, I'm still considering it. But the minute when the cardiologist come in, reinforce, the cardiac surgeon come in, reinforce, it sort of strengthen their confidence and impress on them that it is important for them. Now, as for nursing and the healthcare professionals, we should be reinforcing, right? Reinforcing them. You have the cardiac rehab team have come to see you. What do you think? Reinforce, and I think you should go for it. It will be good. And then usually, I know not all hospitals have a cardiac rehabilitation services. Not all hospital has a cardiac rehab nurse, but if the hospital have a cardiac rehab nurse, she has a very dedicated role to be able to follow up, counsel, coordinate, how to make that sort of transitioning patients from the phase 1, phase 2, phase 3 smooth. Because if they find it very malecious and very troublesome, they find they will drop out. Next. It is important to have an equitable cardiac rehabilitation delivery models, meaning the cardiac rehabilitation should not be just for those rural areas. In area where they have poor internet connectivity, meaning that there is no way to reach out for them. Right? What about those lower educated? And what about those from low income? Now, we have to make it, everybody have an opportunity to access cardiac rehabilitation because it is proven benefit. So you may start with de novo. De novo meaning is whatever you have it, you just sort of transform it, or you improve it or make it new. Now, nurses would be in a wonderful place to play an active role. The only thing is, sometimes I find nurses hesitate to take the leadership role. Okay? They dare not take the challenge. I remember last time when I discovered, I started this kind of project just by when I was doing a survey. I talked to a lot of patients and I listened to their sad story. It saddened me to see some patients come and tell me, "Oh, I can't join cardiac rehabilitation. I stay so far away, impossible for me to come to the hospital. So I just live my own life." Okay, and then at that time, way back in 2018, we have not had pandemic. There is already talking about digitalization. So I was sort of, how to start? So, some or other, you go around and talk to people. I talk to my cardiac physician. Hey, you get a group of people that sort of agree with you and let's do something. You build your team. So I remember when we applied for grant and then, I'm being the old generation. I do not know much about technology, but I will just never mind put in a grant. And lo and behold, small grant has been started. I started with a small grant, and that small grant is where it's like a beginning to the development of the project, because it starts small, and then as the time goes by, you do a pilot, you do small. I find I learned a lot. Okay, there's a lot of challenges. It was completely steep learning curve for me. I never. There are a lot of those. Should I say IT languages I'm not aware of, but I'm learning along. And then when you build a pool of people, you have to forge effective collaboration. You have to find people who like-minded like you, who like to be on the same journey, who believe the same visions. Therefore, work together as a team. You can take the lead, and then what happened is subsequently when I have started it small, then my others team started to build on it. Now the grant has been passing. It's okay. From one grant, the next person will apply the grant. So that's how we expand. And now we're still in the process of expanding it, and then we're excited to see how it will go along the way. And I will say to you that you do not need to know everything. You do not need to be a top tier experts to be able to take up something that you believe, and you have to believe that it will benefit your patients. So that's just dare to take up challenge, dare to take up leadership, right? Learn to forge effective collaboration, because this kind of journey you can't do alone. You have to have a good team, the team that comes with different expertise, and let's go and learn along the way. Learn, it will get better. And you have challenges, never mind. Challenges are meant for us to learn, and we can overcome it. It can, and then in the end, we will win the battles, one step at a time. Next, what will be our next role besides taking on the leadership? Now, we need to be an effective advocate. Now, we are the patient advocate. So we are in the position, we were there with the patient 24/7. We will know what works and what not works. Cardiac rehabilitation is very, very much personalized. You cannot have a same program, for everybody. It's the same. Because, I give an example, if it's a Muslim lady, you do not expect them to come. Some of them are not comfortable to join a cardiac rehabilitation that will have mixed men and women. Maybe you will need to have a separate session for them. That's one example. Yeah, and then you have to tailor the education. If your patient has smartphone, you can use that sort of device to maybe give them some video clips or whatsoever. But if your patient comes from an area, then you have to go back to the basics like pamphlets. It's still, you do not throw away the pamphlets. It still works. So you have to tailor your education, the way you counsel, and your care coordination. Then you have to be an effective team members of the cardiac rehabilitation. And you will always, as you do your work, don't just be routine, but you must have observation, get feedback. You must have, continuous quality improvement plan, so that whatever you're doing will get better as the time goes by. So you don't stick to the same way of doing it year in, year out, day in, day out. And of course, be updated with latest development. Attending conference, like you are joining here, you are here to find out what's new up there, what's happening up there. That's a good start, right? And then keep yourself abreast with the latest development. And then when you want to be an effective resource person, you do not forget those underprivileged, those deprived group, as I mentioned, older group, ladies, low income, low educational. Okay, these are the deprived group. So these are the ones that sort of deserve an additional attention from us to encourage them. Hey, okay, you cannot afford. Maybe there's some form of mechanism that is still affordable to them. Right now, you will see a lot of those digital devices has become cheaper and cheaper each day. Now, like the wearables that I used to wear, it used to be 700, 800. But you can see nowadays there's a cheaper brand. It will cost 200, 300, a decent one. You have to make sure it's a decent one. You have to test out to validate the device is a decent one. Then you have to support the patient health literacy and digital literacy. Health literacy is mean that when you deliver your health education, you have to really tone down. Now, if a person from the lower education, you do not speak too technical, maybe your pamphlets shouldn't be too wordy.
Excuse me, Dr. Lee. My apologies for interrupting. You still have 5 minutes more to finish the presentation.
Thank you. Yes, I'll be able to finish it. Yeah. So you will be. Thank you for reminder. Okay. So you have to look into whether they are good in handling digitals. Right. You have to also provide a culture and linguistic appropriate cardiac rehabilitation and look at their cultures and the languages they use. If they do not understand English, then you have to give it in their mother tongue language, and you have to build rapport with patient. Yeah, you have to build that rapport, because when they connect to you, then you will see that they will follow you. They'll be able to complete it and not drop it out. Right now, this is sort of the last slide. Okay. At the end of it, I think nurses should be a researcher. Okay. If you're not a researcher, then be a team members. Okay. Collaborate, in a team that's doing research, especially if you have your fellow nurses who's doing research. Give your fullest support if you are staff nurses. Conduct research, because if you want to transform, you need to have science. And you have science. You need to do study. What works, what doesn't work, come with empirical evidence. Then you have to apply it so that you hopefully, as we collect more evidence, now we are running a lot of different types of cardiac rehabilitation program, and we get feedback. We see what's are the challenges, what can make it better. Now, with that what's going on, we hope that we target that from 20% participation, we hope to aim about 70 or even 80. participation, because we want as many as possible our cardiac patients to have a better quality of life. And then we have to look at all these aspects along the way. Who will be benefit? How can we improve the deliveries? How it can be delivered? And what will be the effect that we should be measuring? So there is an exciting research work going around all over the world. And I hope that to see maybe nursing departments of the Polytechnic Kementerian Kesihatan Gorontalo will be embarking on one of research itself. And feel free to collaborate with us. You can email me, then we can have conversations. And this is my additional reference. Right. And with that, I thank you for your attention. Right. And I'll be more than happy to take any questions or any comment that you have. Or if you don't have comment, you would like to share your thoughts, I'll welcome it, because I believe that learning can take two ways. Right? I can learn something from you too. And with that, thank you very much.
Yes, you're welcome, Dr. Lee. Thank you very much for your presentation. It is very interesting how technology transformation take roles in monitoring and referring for patients with cardiac disease. I hope we can adopt it in Indonesia already. Next, we will moving to the question and answer session. For this chance, we have one question for you, Dr. Lee, from our nursing student.
Yes.
So, please, I over to the student to deliver the question.
Thanks for the opportunity. My name is Christina Sinsia Singal, the first year student of nursing of Gorontalo Health Polytechnic. I want to ask about how does the healthcare system in Malaysia address the prevention, early detection, and management of cardiovascular disease? Thank you.
Okay. You repeat that again.
Excuse me, can you repeat it again for Dr. Lee?
Okay, thanks for the opportunity. My name is Christina Sinsia Singal, the first year student of nursing of Gorontalo Health Polytechnic. I want to ask about how does the healthcare system in Malaysia address the prevention, early detection, and management of cardiovascular disease? Thank you.
The preventions and management of cardiovascular
disease.
Yes. I will make it clear. Excuse me, Dr. Lee. The student asking for how the healthcare system management in Malaysia to make as possible to prevent and to giving nursing care for patient with cardiac disease in Malaysia.
But in the healthcare system in Malaysia, we have the whole ecosystem of how to manage. So we do have something called like primary health, secondary health. Okay, so when the best is actually prevention. So in Malaysia, we have screening. We have a lot of awareness to tell the people you need to take care. The cardiovascular disease is number one care. So meaning that before the patient develop cardiac diseases, when they do screening, they already got hypertension, they have diabetic. That's where already we start to address them. And this is a risk factor to cardiovascular diseases. That's the very starting. So we have a primary health clinic with primary health nurses. These are the nurses that do a lot of teaching to talk about diabetic care, to talk about hypertension. Before they even get heart attack, we always ask them, and these are the patients that need to come for regular follow-up. Then that's one system. We have a primary health care system and a primary health nurse. The next, when the patient has an event like stroke or heart attack, they enter into the hospital system. So in the hospital system, we in Malaysia, we hospital like us, we have a very specialized cardiac center. There are many specialized cardiac center. Unfortunately, we do have to work on our rural area. And that's where we are working on. We want to improve the healthcare system in the rural area. But now, no worries. Even the doctors in an area where they don't have specialized cardiac services, the doctors can have teleconference with the cardiologist that is centered in a cardiac center, which is usually located in an urban area. So we will have a team. Now we have a cardiac ward just specifically for patients. We have cardiac ward like CCU, coronary care unit, HGU, and then we also have a ward for those who come in for cardiac procedures and meet them one day. We also have a CAT lab. Then we also have a CICU, coronary intensive care unit. These are the patients after surgery bypass. They will be nursed in an ICU. This ICU is very uniquely meant for cardiac patients. So that we have Institute Jantung Negara, and these are our Malaysia cardiac center. Even it treats our prime minister, ex-prime ministers. And then in like my hospital, is also one of it, right? And then we have a lot of cardiac center. So that is tertiary. That is tertiary care. So after we treat them, recover from that adverse event, recover from stroke, recover from heart attack. Therefore, we move them to a rehabilitation. So rehabilitation is important because you want them to be able to retain their life as normal as possible. You want them to overcome all the psychosocial issues they have. So what we do, we refer them to another services. It's a separate service. We call cardiac rehabilitation services. So many big medical centers have that. However, in certain small government hospital might not have that. That's where we are looking how we can have if we can successfully digitalize our cardiac rehabilitation service, we can also reach out to those small medical centers that do not have specialized service, but they can connect with the specialists here at the big medical center. So that we are moving towards that. So these are basically how the should I say the ecosystem of healthcare in Malaysia in managing patients with cardiovascular diseases. So I hope I answer your questions.
Yes, it is really clear. Thank you very much for explanation. We still have one question, Dr. from the participants. The question is from Irma Riani on our chat room from Universitas Indonesia. The question is, how nurse face challenge where the role of nurse will be replaced by technologies such as artificial intelligence in the management of heart disease? And then how to ensure patient compliance in treatment with the help of digital technology?
There are two questions there. Thank you very much for the question. I think that is really, thank you for asking, because I think that is really a question that actually is playing in our mind.
Yes.
Number one is, can all this technology replace human? I don't think so. I don't think so. As far as I know, but I can't say, in another couple of decades to come, we do not know. But you see that all this, even AI, so you talk about AI, so now, some of you were asking AI. AI is an exciting development, is like an intelligent machines that help us basically to reduce some of our manual work, like automatically refer patients, automatically matching patients. You know, there is also a work that they try to have a support group. Right? There's the AI machine will sort of match make. Okay, these are based on the characteristics. So you form this support group, or automatically sort of answer some of the concerns, basic concerns when the patient want to know how come my heart can get blocked, what is PCI, what is stent. So these are the machine that can do some of the work, and it really will be very helpful, you know, because it reduces the workload. Patients, cardiac patient is really a lot, and the nurses, the physiotherapists, the healthcare professionals are limited. So if we can get this machine to reduce our workload so that we can concentrate those that is important. So we focus on that very ill one, the complicated one, so we can focus on those monitoring, you know, encouraging patients. If we can concentrate that will be much better, so that we do not waste our, so that we can conserve our energy from all those manual work, light work. Yeah. So don't think the AI will ever replace us. And at the moment, we are not really ready yet because our data are not enough. To have an AI, you have to have a lot of data. So there's exciting work going on. So you just need to watch out for the next 10 years, see how it goes. Question number 2 is what already? Can you repeat?
Is how to ensure patient compliance in treatment with the whole of digital technology.
How to ensure patient compliance?
Yeah, patient compliance in the treatment.
It's a very tough question. There is no formula. Definitely no formula, because why patients fail to comply is not because of patient's factor. Okay, but you also need to think about the environment. Okay, how to comply when no car to drive to come, right? How to comply when the cardiac rehabilitation is so expensive? How to comply when the way you teach, you know, they couldn't understand. So to address the issue, you really need to know one thing: what are those barriers that I mentioned before? Okay. So when you assess, interview patient, know what their limitation. Can they drive? How much they earn? Are they educated? What is their religion? Because religion play a role. What's their cultures? What's their like, they don't like? And get that data. So when you structure a personalized care plan that address all those issues, then you can come up with a plan that memenuhi cita rasa lah, in other words, that fit them, and more likely they'll be more than happy. They feel they can do it, and it fits them, it fit into their lifestyle, because they're also working. Remember, they work. If they work shift, you have to consider that. So if you plan that well, then you'll be able to reduce the dropout rates and increase compliance. I think nurses, very important that you need to know your patient very well. You need to engage with them. You cannot let them go. Periodically, even though you have all the exciting digital technology in place, you have to have a plan. You connect with them. You can connect them, maybe not face-to-face. You can have virtuals or even support groups in a WhatsApp chat. Simple as that. But when they feel they are connected to the healthcare professional, they will stay in the system until to the completion. That will be my tip. Yeah. Thank you for the questions.
Yeah, you're welcome, Dr. Lee. That's very interesting that we can provide such a support group for make a connection from the health worker and nurses for the patient. And the technology also very really helpful to reduce the workload of cardiac nursing that intend to be very high in the hospital. Ladies and gentlemen, and yes.
I will conclude one thing. Technology
Yes.
must be hand in hand with human touch.
Yes. Yeah, thank you very much, Dr. Lee, for your outstanding presentation and your
Thank
knowledge
you.
sharing to all of us. Because we are limited by the committee for the time. As our respect, we will present the certificate appreciation for you from us. Is the committee. Yeah, this is the certificate appreciation. Please give applause for Dr. Lee Wang Lee, PhD, RN. Thank you very much. As information, our conference held hybrid, so we have 100 of students here. Say hi to Dr. Lee Wang Lee, to all of the participants here, our nursing student in Gorontalo Health Polytechnic, greeting you.
Selamat maju jaya.
Terima kasih, Dr. Lee. Thank you very much again for Dr. Lee. We will hope that we will meet in another chance.
Definitely.
Thank you.
Bye.
Thank you very much, Dr. Lee. Right. All of the conference participants. Now we are moving to the next topic of this conference. At present, at present we will going to focusing on another cardiovascular disease. On this time, we will discussing about how hypertension management health. Ladies and gentlemen, as we know together that CFR management is the key of success in managing hypertension and involved with the older of the patient. And to discuss about this, we have invited the other expert speaker, Andi Mashita Irwan, SCAP NS, Master of Nursing, PhD. Good afternoon, Mrs. Mashita. Are you already joined with us? Please, the committee, can you help us for solve the technical problem? Yes. While going, the speaker joined with us, let me read the curriculum vitae of her. Her education history is in 2016. She earned his PhD in nursing in graduate school of health science at Kanazawa University. And in 2021, she continued to postdoctoral fellow at School of Nursing, University of Michigan, USA. And let me read her some professional experience. At present, she holds the responsibilities at Head of International Office, Hasanuddin University at Makassar, Indonesia. And in the same year, he also joined in research collaborative professor at Kanazawa University, Japan. And besides that, she also got some short course in 2013. She ever joined in international program in health promotion, quality of well-being in Aging Institute, United Nations in Malta. And some professional goals of her is she is the member of Sigma Theta Tau in 2022 and member of Indonesian Geriatric Nurse Association in 2020. And for the publication, it's very and really inspiring for us. She has published more than 70 international and national research articles related to older people nursing care. And one of her research, referring to our team today, her title of research is Development of Self-Care Program to Reduce Salt Intake among older patients with high blood pressure, a randomized control trial. So that's the summary of her curriculum vitae. And now we honorably invited Mrs. Mashita Irwan for joining us to present the material for today. Good afternoon.
Good afternoon, Nurse Ria. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon, everyone. It's an honor for me to being able to present such a prestigious international conference conducted by Poltekkes Gorontalo, Kemenkes Gorontalo. And I met some of the familiar faces such as Okay, can you hear my voice clearly, everyone?
Yes, we can all
okay. Sorry. So good afternoon, everyone, and Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for inviting me in this very prestigious international conference hosted by Poltekkes Kemenkes Gorontalo. Such an honor to meet all the people, even though it's online. But few minutes before Dr. Lee ended her presentation, I could see that there are a lot of students in here attending the conference offline, which is, I think, very good. And then thank you very much for the enthusiasm. I also want to greet Dr. Lee. Thank you for the presentation, Dr. Lee. I also learned a lot from you regarding the topic. And then can I share the screen? Wait a second. This one. Okay. Can you see my presentation?
Yes, it's in here now.
Yeah. So I gave the title to the committee regarding health coaching to manage hypertension, self-care among older people. So in the past 2 years, I involved actively to conduct research about health coaching and the implementation for the hypertensive older people, especially in Indonesia. So that's what I intend to share this afternoon. So the outline is we are going to discuss about hypertension among older people, not only in Indonesia, but also around the world. And what is the connection between hypertension and self-care? And what is actually self-care problem, especially among older people? And how self-care and coaching could connect? And what is the implementation of coaching? And then at the end of the meeting, I'm going also to share some of our output or findings because currently we are conducting a kind of pilot study to test the feasibility of this coaching to be implemented in Indonesia, especially for older people. So in 2025, it is predicted that 1/3 of the whole population will have hypertension. And as we know, when the blood pressure readings is equal or more than 130 millimeter, or the diastolic blood pressure reading is equal or to 80 millimeter Hg, it is classified by American Cardiovascular Center as hypertension. And hypertension incidence is more prevalent occur among older people compared to young and middle-aged people. And the same condition also found in Indonesia, whereas based on the basic health research or Riskesdas, you call it in Bahasa, in 2018, the highest percentage of people who suffer from hypertension was group of people among 65 until 27, which is older people, or you call it lansia. And then hypertension is a primary risk factor for stroke, heart disease, and kidney failure. So it's a kind of very serious problem because it could be a leading door to a more negative and then more fatal health problems in the future if it is not managed properly. So hypertension is a risk factor, and then we need, as the health worker, we need to reduce hypertension because it is a significant emphasis in primary and secondary prevention and treatment. So what is self-care and hypertension? Once older people diagnosed with hypertension, that means they need a long-term treatment. They have to consume their medication during the lifetime. And then if it is not properly treated, hypertension could decrease independency, quality of life, increase morbidity and mortality, and it has also become family burden for older people who stay with their family. They could become family burden for their family member, and then also mortality. That's why, therefore, self-care management is needed. And then actually self-care is developed by OREM. It is one of the big nursing theory studied widely in nursing world, and it is a series of behavior or action to maintain health. And then especially for hypertension, there are specific recommendations recommended by Joint National Commission. So it is regularly released to give guidelines for the health worker on what to do about the hypertension. And then the latest recommendation is the 8 GNC, stating that self-care activities including medication adherence, body weight management, dietary intake, alcohol consumption, tobacco cessation, and physical exercise are recommended activities to manage and then to control hypertension. If the self-care of hypertension is implemented correctly, based on the previous studies, it could decrease blood pressure, increase adherence to antihypertensive medications. It could reduce complications, as I shared earlier, that hypertension could lead to stroke, heart disease, kidney failure, and etc. It could decrease by implementing the self-care, it could reduce the potency of complication, also decrease mortality rate associated with hypertension. And another benefit is could also decrease healthcare cost. So you can imagine that once some people diagnosed by hypertension and have series of health complaint, they will go to the public health center, to the hospital regularly and frequently, and then they should pay some amount of money for the treatment. But with controlled self-care hypertension, we could reduce the healthcare cost. But there are some problem about hypertension self-care. Based on, in 2022, we released a scoping review measuring and then describing about ability of all of hypertensive patients in Southeast Asia. We want to know and identify what is actually the problem of hypertension self-care. And then we found on that published scoping review, we found that hypertensive people in South Asia, including Indonesia, have low implementation of body weight management, lacking of physical exercise, poor quality of diet intake, and non-adhere the medication. That means that once they are having antihypertensive medication prescription, usually some of them only consume the medication when they feel dizzy, nausea, or the blood pressure is increased. But when the health complaints stop, they also stop to consume the medication. And then we also found that the problem of some people with hypertension is different from one to another. For example, one patient struggling to maintain their body weight, while another patient have difficulty to do physical exercise, while the other is being not regularly consuming their medication. So one people have different problems, not uniformity have problem, or not all the problems found in only one people. So the problem is individuals different. Therefore, different approach with personal attribute and external circumstances are really essential to solve the self-care problem among hypertensive patients. That's why we need to better understanding about what is actually the problem of each people with hypertension. Therefore, coaching, which is help to better understanding of self-care problem, could give better response on how to solve the problem for each people. And at coaching, older people is encouraged to determine what is actually their target. For example, if the problem is older people with hypertension having a problem of obesity, so what is their target? Whether their target is to decrease their body weight into, for example, 2 kilograms in a month or 4 kilograms in a month. So what is your target? So the target is individualized, determined by the patients. And then in coaching itself, it's combined not only active learning, not only health education, but also combination of what actually do you need to know, what you want to do, and then we will help you with the specific health education to achieve your target. For example, your target is to maintain your body weight, or your target is to being able to regularly consuming your medication. And then another thing, benefit of coaching is that it could rapport building to help determining target and evaluate progress. So in coaching process, we are not only helping them to identify what is the actually target, but also to help them to practice the needed action or behavior, and help them to evaluate at the end of, for example, 2 months, to compare with the previous target, whether it is achieved or not achieved yet, or need modification. And then by coaching, it could motivate patients to do better self-care management. So what is actually the concept of coaching or theory of coaching? So if you read the references, there are a lot of coaching theories that you could adopt. But the one that I focus and learn deeply in the past 3 years, because I also learned about this coaching concept during my postdoctoral time at the University of Michigan, USA. In the last 2 years, I attended the coaching program and become a certified health coach from the United States of America. We adopt the Healthy Lifetime Theory, or HL, which is the combination of motivational interviewing concept and cognitive behavior theory. It could help to equip and motivate older adults to improve and maintain self-care management of older people with hypertension. And then by this coaching model, with earlier intervention, longer-term benefits of changing their health behavior and preventing negative consequences could be achieved. And then some of you might ask how to do coaching, how long it would be, and then how many times I should give coaching session to my patients. So based on this Healthy Lifetimes, 30 minutes coaching session per session for 8 times if needed. So coaching is a kind of long-term intervention and regular and need consistency. And here is the, the concept of health lifetime coaching. So there are several techniques I will explain later that we use to help the patients, or in this occasion, the older people, on how to help them to achieve their target. So through 8 weeks, from week 1 to the 8 weeks, we do some of the communication techniques and skill and motivation techniques to help them. For example, engaging, building rapport, and etc. I will explain to you letter one by one, and at the end it could build a sustainable behavioral change. We don't want something that only will stay for 2 weeks, and then, for example, we help the hypertensive patients to start to do physical exercise like walking, running, jogging, or swimming. But what we want is they could do it regularly, consistently for their lifetime. That's why we need to accompany them throughout 8 weeks to help them to adopt permanently the behavioral change. So what is the coaching component? So there are some elements that we need to do during the coaching process. The first one is rapport building, betting technique, giving advice or information, focusing, assessing self-confidence, and the last one, planning. How to do that, and then what we need to say to the older people or patients, I will share I will share the next slides. The first one is about rapport building. What we need to do first is to do introduction, introduce yourself, who you are, and then what is the aim of this coaching. And then the second thing to do is you should ask them. Yeah, of course, you know that they are hypertensive patients, older people, but you should ask them, what is your current health problem? We know that their blood pressure is increased and have been diagnosed by hypertension, but what is actually their problem? Based on our experience giving coaching to older people, they might say that I always feel dizzy. My back of my neck is very rigid. I feel that feel nausea. I want to vomit and etc. That's the first door to start to identify what is their actual problem related to the hypertension. So we ask them, what do you think it could happen? What is the cause? What makes it happen? And then what do you think feeling nausea? Why do you think feeling dizzy is the problem? They might say because it is interfere my daily activity. It makes me cannot attend pesta perkawinan or wedding ceremony. It makes me should cancel to go to acara akikah and etc. What else? It makes me could not sleep. I cannot sleep because I feel dizzy, I feel headache, or I feel that my heart is a bit faster than previously, and etc. So you ask them after you identify what is their problem. What do you think? Why do you think it is? Why they think it become a problem? And then we could start to. So do you want the health claim to reduce it? How important for you to reduce it? So coaching is a kind of giving series of questions, letting what is the answer. So it's a kind of we help them to identify what is the actual problem, why they think it's problem, and then do they think it is important to stop the problem or not? That's part of rapport building. Another step is if they decide to, for example, to stop the dizziness and etc., ask them to try to imagine how would your life be different and better in the 6 months. If you do something to stop this matter, what do you think your life would be better in the next 6 months? So we ask them or we encourage them to engage in a kind of imagining their life better if the health complaint is stopped. And then we also tell them explicitly that it is up to you, not up to me as a nurse, but it is really up to you. If you decided to stop the problem, how would you go about getting started? What do you think we need to do first to stop? They might say, it seems that, for example, I need to do more exercise, or it seems that I'm having difficulty to move because my body is too heavy. I'm being fat and etc. So if you decide to decrease, for example, your body weight, what do you think you are going to do first? So this is a kind of series of engaging patient to talk and then express their opinion. Some of you might think how we can make Indonesian older people to do that, because they usually always asking us to teach them. But in this coaching concept, they are the one who should decide. They are the one who should determine what is their target, what they want to do, and etc. Another thing in the rapport building component is give short summary or reflection. The sample is like this. I understand that you already told me that you think dizziness or the back neck rigid is very disturbing your activity. That makes you could not go out to attend several ceremonies and etc. That makes you could not see your grandchildren because you always feeling not healthy and etc. I really appreciate. So this is something that nurse should do. Sometimes we forget to to give a praise the patients, memuji pasien that you are great because you already tell us or you already tell me what is the actual problem that you, and then you tell me that this health complaint makes you or limited your activities to do many things. And I also appreciate that you are aware that we need to work together to stop this one. So please give summary of or reflection or of what they already told you, and then end with a question. So what do you think you will do? Where does this leave you? What we are going to do? What is your first step? Or what do you need to do to prepare for your plan? So again, once again, coaching is a kind of, we give the key to the patient. If it is a car, we give the patient opportunity to drive where they want to go. And then don't forget to listen with interest, with a kind of nodding, and then saying, okay, I listen to you. What else? Okay, that's good. Something like that. And provide an affirmation. Another, the second element after we building rapport or building good relationship with the patient is betting. Betting means that we acknowledge that patients have struggling to have good behavior or certain behavior. So the example like this, they might say that actually if the problem is they do not consume the antihypertensive medication regularly, and then they say that I don't have enough money to go to Puskesmas, to the public health center, because I have to go there with Bentor, with the tricycle or public transportation, and I don't have enough money to pay the public transportation, for example. That's one case that we find during our pilot study. And then you might say that as the coach, I get that and then they say to you that I know that I'm supposed to be taking my medication, but I'm having a hard time paying all my copays. I have to eat, I have to buy food, and at the same time, I need to spend money also to buy medication, and it's difficult for me. Maybe that's what patient told you. But we in the coaching concept, if the participants is willing to keep talking to you and mention their problem, that means that the successful responses, because that means that they trust you to talk about their problem and also to talk about their ambiguity or their confusion about, I know I'm fully aware that I need to improve my health condition, but at the same time, a money problem or financial problem become something that would stop me to consume the medication regularly. So in the betting process, as a health coach or nurse coach, you should admit the challenges that I understand that you really want to drink your medication regularly, but at the same time, you also have financial problems to pay the medication. So you should admit the challenge, but help to reflect that they are eager to change the behavior. You should admit that, but I'm really happy to hear that you are fully aware that consuming medication regularly is important. So it's a kind of, we give affirmation. But this is the, how to say, the challenge as the health coach. Sometimes, because this is what we usually do in the past, usually nurses or health worker always ask the patient what to do. But in the health coaching, the main difference is you should hold yourself, not to tell them what to do. Patient is the one who should find what kind of solution. So, for example, you cannot say that you should drink your medication regularly. It's not good if blah, 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 blah. You should ask them first, is there any idea? What do you think? And what do you have any idea to solve the problem? What do you think? What we can do to solve this problem? You should ask until they find their, their solution. Another element is giving advice or information. If the patient do not know what to do and they ask you, do you have any suggestion for me what I should do? Do you have any information? Or for example, they said that actually I don't know exactly what to do to improve my health condition. Can you tell me what I can do? So when they express the need to have health education, that's the time when you start to give health education. But because sometimes lacking of knowledge is not the problem for older people. They already know everything about how to manage hypertension, because people from Puskesmas or nurse from Puskesmas or public health center already told them so many times, you have to drink your medication regularly, you should exercise, you should reduce your salt intake, and etc. They know everything actually. But sometimes the problem is they need somebody to listen to them about what is actually the main problem. Not all older people with hypertension having problem with obesity. If you see in the community, our older people are slims. They are langsing. Only some of them who have obesity or excessive fat. So when you need to giving advice or information, is you should determine first what they already know and what they don't know. And then if the participant asks for clearly or want information or tips, that's the time when you give them. And then you should ask them also, if I explain to you about how to reduce your salt intake, what do you think this information will be useful for you to solve your hypertension problem? So if they think that, I think I'm going to use the information you give me to manage my salt intake at home and my family salt intake. If they say like that, so we can ensure that the information will be used by the patient wisely. And then if they say that they need health education, you should make a time appointment. So not already jumping, okay, I will give you health education, I will explain to you what is hypertension, what is the consequences of hypertension, etc. That's not the case in the coaching concept. At the next meeting, we could give them health education session. Because in this coaching, there are 8 times meaning to say, for example, 8 weeks to do coaching. And then in each session, it is only 30 minutes. Why 30 minutes? Because after 30 minutes, usually it's not efficient anymore. Moreover, for older people, they usually already have time. They are fragile to very long time, need to focus. It makes them exhausted, and then sometimes it makes them dizzy. So 30 minutes maximum is needed. Another concept of coaching is focusing. So for example, if you find hypertensive older people who have series of problems, we usually find it in our pilot study. They are having obesity. They also having lack of physical exercise. They also have high salt intake, because we measure their salt intake from the food and then from their first urine after 24 hours. So sometimes we ask them to choose, which one do you want to focus first? Whether you want me to help you to reduce your salt intake, or do you want me to focus on how to manage your diet or what? So the patient is the one who decided if they have multiple health problems. Another thing is assessing self-confidence. So we should assess their confidence in doing behavioral changing. With the sentence like, at the present time, with 0 being the lowest value and 10 being the highest, how important is it for you to stop smoking? Or what makes you choosing 5 from 0 to 10, you choose 5 instead of 3? Why? What is the reason? So asking them. Or for people, they said, if we said that if there is a scale 0 to 10, and then where 0 is being the lowest confidence until 10 is very confidence, in which value or score you think that you confident to stop smoking, for example. And then they said that I choose 7. Why 7? Because I think that I need to stop smoking because I want to see myself in a better health condition in the next 6 months, for example. Or I want to live to see my grandchildren grow up. Some of the patients told me like that. Another thing, another sentence you may say, what would it take to get you to 9? In addition, you said earlier 7. What could take you to make you 9? What else? Until we believe that they are confident enough to change their behavior. And then the last sentences or question for this self-confidence concept is, if you decided you were ready, who or what could help you to make this change? They may say that I want to start to reduce my cigarettes. In the past, in one day, I could smoke 10 cigarettes, and I'm planning to reduce it in 2, for example, 7 or 6, and etc. So we should ask them what is the actual action that they want to start for the behavioral changes. This is also another sample of sentences to asking self-confidence. But the point is, we should help them to realize that how confident they are, and then what they want to do to start the behavioral changes. The last thing in the coaching concept is planning. The things to do this planning, sometimes I take the paper and then make a column, and then the column at the left side is barriers and challenges, and then the right column is about what is the how to say it, not benefit, what is the thing that could support you. So it's a kind of inhibiting and prohibiting factors. For example, in one of my patients, we found out that she has a very high salt intake in the urine, meaning to say, so the ideal salt intake is about 6 milligram per day, or equal to 1 people to consume in one day. And then we found out that she has 13 gram. The last time in the last one day, she consumed 13 gram. That's mean double of the ideal minimum of the salt intake. And then we show them the result, and then that this is the result of our test, and you consuming salt too much. What do you think? Is it the problem? And then salt is contributing a lot with the hypertension, and then this is one of your problem. Do you want us to help you to solve the problem or not? And they say, okay, I want to do that. So at the planning concept, usually we ask them, what do you think the barrier for you to adapt or to reduce your salt intake? One of my patients told me that I'm having difficulty to reduce my salt intake because I cook for one house, and then I cook for my children, my grandchildren. And if I reduce the salt intake, my children will complain to me because the food is not delicious anymore, like in the past few months or past few years. And that's what happened. And then what else? The barriers. And then she said that I love salty foods such as dried fish. I love to eat telur asin and etc. And then we asked them, what do you think the things that could you do to reduce the salt intake? So the patient started to think, and then she told me that it seems I could reduce the salt intake because I'm the one who cook at home. I could, for example, separate my food and my family food. And then what else you can do? And then she said that I think if I start now, it might need sometimes to adapt. But if I'm thinking about my condition, I think I will get used to that. So it's a kind of, we help older people to think about what is the difficulties and what is the positive thing and etc. So after that, usually I summarize what she said. I told her that after we are talking today, this is the result. You told blah, 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 blah for the difficulties. And then this is the one that you plan to do. And this is the benefit and etc. And then after that, I asked her, so what you are going to do with this one? What do you think you can solve these problems and start to this thing or not? So that's the process of doing planning for the coaching concept. So coaching procedure, like I said before, it should be 8 sessions or equal to 8 weeks. And every session consists of 30 minutes to ensure sustained behavioral changes. Where it could be done, usually I do it at the home of the participants, home of the hypertensive people. It could also be doing at the public health center. And sometimes it could also be doing at the polyclinic or outpatient clinic. Or for the public health center, public community health nurse, they can do that during their home visit. But one thing to should be remembered that this coaching session should be done in a calm environment. If it is too crowded or too many people, sometimes the participant or older people cannot talk freely and openly to us. So this is the challenge that we found when we start to implement this coaching model to older people in Indonesia. I published a paper in 2016 regarding salt intake among hypertensive older people in Indonesia, and then we also determine their health literacy or ability to use the health information to improve their health. And then we found that among older people in Indonesia, they only have ability to process health information equal to the third grade of elementary school or at class 3 SD. Another challenge that we find during coaching of older people is when to give health information. If we use conventional method, usually when we conducting posyansia or monthly health checkup for older people, usually we directly give them pendidikan kesehatan or health education about how to manage hypertension or other chronic problem. But the coaching session, it could not be like that. And then in the conventional way, sometimes the participant would be a passive patient. We keep talking, and then the patient just keep silent and then sometimes nodding like this, or when we ask them, they say yes, 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 and yes. But at the coaching session, it's kind of challenging because we have to change the way we talk to them, and then it's need time to stimulate and listen. During my based on my experience conducting and implementing this coaching to the older people, it needs time to stimulate them to talk, because usually they are the one who always listen, and then we are the one who always talk. So we need time to stimulate and then to wait. They think what they want to do and then to listen affirmatively. Another thing is because the family involvement, so it's in one side, family involvement is a very good thing for older people in Indonesia, but at some point, older people become very dependent to decide what they are going to do for their health, because they always waiting their son or their daughter to decide when to go to the hospital, when to get the medication, when to do checkup, and etc. And then this kind of coaching is not applied in Indonesia yet, just recently. That's why we conducted a pilot study to 20 older people with hypertension in the community setting to determine feasibility and modification of the program. So this coaching concept comes from the United States, America, and then in the United States, the older people are group of people who are really active, have high education, and frequently asking and then deciding what they want to do, which is very suitable with coaching concept. While in Indonesia, older people have low level of education, usually doesn't have initiative to take action, and that's what we want to help them by coaching, so they can be a key person to decide their future. So this is some of the documentation during we do the pilot study. We check their urine to determine their salt intake. We check the concentration of salt at their food. We talk to them many times. For one participant is for 8 weeks or for 8 times. And then what we get from pilot study? So this pilot study is not finished yet. We are still in the process. It's still ongoing. But some things that I can share to you that we found out that majority of our participants have problem with the high salt intake. And then at the first time, they feel awkward when I ask them what we want to do, what do you need to do, how do you start? It's kind of, they feel awkward, and then they will suddenly silent, and even some of the participants get angry to me because, and then complaining that because they told me that why you ask so many questions, why don't you just tell me what to do? That's what they told me in the first or second session. And usually they're frequently asking what to do, but we found out also that after the second meeting, usually they start to practicing what they want to do. For example, some of them start to reduce their salt intake. And in the third session, when I come again to the coaching, they told me that they experience several good things, such as reduce of the back rigid neck. They start not to feel nausea again. They start not to feel dizzy, and etc. And then the challenge also relies on sometimes they feel blank about what to do. Sometimes even they told me, you told me what to do. Usually, Prawat told me what to do, not me who say what I'm going to do. So it's a kind of challenging that we found during our ongoing pilot study. So as the closing, we realized that this coaching concept have room for improvement, especially we should adjust with the culture and environment. This concept comes from the place where older people are very independent, and then high education and decision maker for themselves. But viewing the benefit of this coaching to help older people to solve their chronic disease problem, self-care, we tried to implement with modification for Indonesian environment and for other other developing countries with similar characteristic with Indonesia. So I just want to say as the closing statement that older people is the decision maker for themselves, not their family, not their spouse. They are significant people for older people, but again, older people is the master of themselves, not others. So I think that's from me. Thank you very much. If you have some question or you want to discuss, Fiona, I'm available to answer and then discuss about your question. Thank you.
Yes, thank you very much, Nurse Masita Irwan, for the presentation. From your presentation, I can imagine that I'm sure all of the participants also agree with me that if the all of community nurses, family nursing, implementing the health coaching approach, I'm sure that we can change gradually the self-care management behavior of the older patients. And as information for you, one of our research team in Gorontalo also developing the same research, especially in motivational interviewing, but for different patient, diabetes patient. I hopefully we
That's
can
good then.
further
Yeah.
doing the collaborative research
Yeah.
for our institution. Yes, we're moving to the question and answer session. We asking some question for the participant on the Zoom meeting and on the auditorium. Oh, okay, we have one question, nurse, from our student here.
Yeah, please.
Yes, to the student, please delivering the question. Yes. Mention your name. Yes, please.
Thanks for the opportunity. My name is Miftah Jana Putri Sawali. I'm a nursing student of Gorontalo Health Polytechnic. I have a question about how far the improvement of family in the health coaching to support the hypertension patient. Thank you.
Yes. That's the question for the participant. We asking for Nurse Mashita giving the
Yeah.
explanation from the question.
Yeah. Yeah, thank you very much, Miftahul Jannah, for the question. We should admit that in Indonesia, family involvement having a very big part in the treatment of older people, especially for those who are living in the community setting. And then based on the one research also, we find that 70% of older people in Indonesia living with their family member, not only spouse and children, but sometimes we found out until one family, there are until fourth generation. So not only grandchildren, but great-grandchildren. And then we found it in Makassar also. Meaning to say it's the reflection that family hold a very important part in the management self-care of older people, especially who having chronic diseases. So in the coaching process, based on my experience, sometimes family also wants to talk, and then sometimes it makes the older people keep silent because family member who takes lead. And then we frequently having this situation for the male participant, because some of them have high salt intake, and then they told me that I'm not the one who cook. My wife is the one who cook. So you should tell my wife about what to do about reducing the salt intake. So sometimes they told us like that. And then we should give understanding to them that the one who become patient is, for example, your husband, and then we want them to take lead and then being a decision maker. That's why we want to discuss with him what kind of things or action that he could do to improve his situation. So after we give kind of explanation to the family member, usually we talk with the participant, and then, for example, the participant, he decided to tell the family member that I need to reduce my salt intake. This is the kind of ingredients or bumbu you could add to my food that even though you reduce my salt intake in the food, my eating appetite will not be lessened or lose. And then we found some of the situation like that for 2 or 3 male participants in our study, and then they even asked me that what about if you give me some of the guideline, I will read it and then please give it also to my family member so they know how many salt they should put in my meal in a day. Another thing is we are fully aware that we cannot separate them. So sometimes family member just sit beside the participants and then also listening. But we encourage the older people is the one who should decide, is the one who should talk, and then want to determine what to do. So once they are motivated, usually the participant is the one who teach their family member. This is what I need to do. You should help me by doing this, this, and this. So I think that's the answer for your question, Ms. Taujana.
Thank you very much, Nurse Masita. It's a very clear answer and explanation. I think because the time limitation, we have to end it for this fourth session. We want to thank to Mrs. Masita Irwan for the outstanding and very helpful explanation about how health coaching implemented to older patients. Thank you very much, Nurse Masita. As our respect,
Yeah, you're
we will
welcome.
present.
Thank you for inviting me also.
Yes. We want to presenting the certificate appreciation for you as the guest speaker for today. So, please the committee. Let's hear the certificate appreciation for the fourth speaker today. Please give applause for Mr. Masita Iran. Here the certificate appreciation. Thank you very much again for Nurse Masita for joining us
Thank
today.
you. Yes, thank you very much. Yeah,
Yes.
bye-bye. See you again.
Yes. Hope we will meet on the other chance. Yes, this is the end of our second plenary session. I would like to thank all the participants who have involved in our second plenary session. And for the next agenda, I will giving it back to the master of ceremony of this conference. So to Andika, and your time is yours. So all of the participants together we ask, we have Director of General Health Worker of Ministry of Health. We're waiting for the response. Yeah, all of the participants we stay waiting for the Director of General Hard Worker join with us to giving some speech and direction for today's conference.
Thank you very much, Mrs. Fahriatul Falah. Next, we move to the next agenda. Distinguished guests, delegates, and gentlemen. Today we begin 2 days of International Conference 2023. We are honored to have a Director General of Health Workers, Ministry of Health of the United Nations to deliver the keynote speech. Ladies and gentlemen, welcome Dr. Gigi Ariyanti Anaya, MKM.
Ya. Halo, halo.
Yes.
Ya. Assalamualaikum.
Waalaikumsalam.
Yeah.
Welcome to our conference, Dr. Ariyanti Anaya, MKM.
Yeah. Thank you so much. Sorry, because of the situation. I'm coming late in this meeting. Assalamualaikum warahmatullahi wabarakatuh. Good
Waalaikumsalam
afternoon.
warahmatullahi wabarakatuh.
Greeting to all of us. Om Swastiastu, Namo Buddhaya. The Honorable Director of Polytechnic Gorontalo, to all our guest speaker from Kanazawa University of Japan, Prof. Makoto Oe, PhD, University of Colombo, Sri Lanka, Prof. Sudat, Prof. Lee Wan Ling from University of Malaya, Malaysia, Patricia from the Virginia State University, Adi Mashita Irwan dari Universitas Hasanuddin, dan Dr. Debbie Dahlia dari University of Indonesia. Distinguished participants, ladies and gentlemen, on behalf of Ministry of Health of the Republic Indonesia, I would like to extend my warm welcome to all of you to being here in International Conference of the Nursing Update and Healthcare with the important theme of the health transformation and management of the degenerative disease program toward a healthy Indonesia. We are honored to host this webinar. I hope the webinar uh, uh, will be is already done, already done, success. Uh, as we know that aging is a natural phase in life, through time, human body experience and accumulated changing leading the degenerative. The body will experience a decline from the previous prime condition in terms of speed, efficiency, and repair. Unfortunately, there are also cases when the certain individual experience premature degenerative. Over time, this degenerative change lead to symptoms and become disease known as a degenerative disease. The degenerative diseases are health conditions that cause a tissue or organ deteriorate over time and lose their function. There are quite a number of types of degenerative disease that are related to aging or worsen during the aging process, genetic problem, and lifestyle choices. The degenerative diseases are caused by the various factors. Some of these factors are a direct effect of the body's normal use, while others are caused by poor health or an healthy lifestyle. And most degenerative diseases can be cured, but there are some cases that cannot be cured. In such case, we find that the available treatment options are to help relieve and reduce the symptoms so that the patient can live with a normal life, even becoming old, but we would like to still live in a healthy, ladies and gentlemen, degenerative disease are relatively common and usually happen in the elderly. WHO estimate that by 2030, at least one in six of the world's population will be elderly. The world population aging, the age become 60 years and over is expected increase from the 1.4 billion in 2020 to 2.1 billion in 2050. The number of the elderly in Indonesia increased year to year. In 2022, that's the total number of the elders, 29.7 million, or 10.8% of the population. It is said that Indonesia has entered an aging population structure, where around 1 in 10 residents are elderly. In addition, this aging population phenomena become a second demographic bonus because the rising proportion of the elderly people are still productive. Unfortunately, the growth of the elderly population in Indonesia is not aligned with the growth in the quality of their years of life. The latest approach to look at the quality of life years, healthy adjusted life expectancy by the WHO in 2019, so that the Indonesian population has an average in the healthy adjusted life expectancy of the 62.8 years from a standard life expectancy of the 71.3 years. It means that the gap of the 8.5 years may due to poor quality of life and disease such as heart disease, nervous system disorder, diabetes, kidney disorder, including disability. Moreover, about 2 of our 5 elderly people have health complaint with the morbidity rate of the 20.71%. For highest degenerative disease are hypertension, diabetic mellitus, cardiovascular, and also stroke. Some of the symptoms that trigger degenerative disease are often overlooked. The emergence of this degenerative disease is inseparable from the increase of stress due to changing in the modern lifestyle and the demand of life. Other main causes are unhealthy lifestyle, yeah, such as smoking, alcohol consumption, unhealthy eating habits, lack of physical activity, mental stress, and environmental population, such as in Jakarta, something like that. Disease prevention and health promotion need to be improved to avoid degenerative disease. We have a six pillar of the health system transformation, which is a strengthening. The first pillar is strengthening the promotive and preventive approach to quality health services will bring healthy, independent, active, and productive the elderly people. The Ministry of Health of the Republic Indonesia has outlined three main programs for the smart elderly. First, that we would like to empowering the elderly. Second, strengthening the posyandu through revitalization of the 300,000 posyandu with the cadre and the medical equipment. And last, developing long-term care program in the community through strengthening family and health services, starting from improving disease screening in community health center to applying elderly service comprehensive and holistic approach by the integrated geriatric team at the hospital. uh, the degenerative disease become issue not only in Indonesia, I think, but also in other countries to increase the health workforce capacity and capability in providing health services on the degenerative. So we need to carry out the strategy. The first is strengthening communication, information, and education anywhere and anytime about the importance of the prevention and control of the degenerative disease. We can control still in the posyandu, something like that. Yeah. The second is expanding the partnership network among the health professional and potential partner with the same vision and mission. And the last is increasing the community empowerment in accordance with the social cultural characteristic so that people know what they want, what they should be to become the healthy habit and lifestyle. At the end, I would like to deliver my congratulations for Political Gorontalo for holding this international conference. Then I know it's already done well, yeah, and hopefully we can get a benefit from the this conference. And my big hope that all the participants always give the contribution and get the benefit and everything to achieve our goal of the health transformation to improve the health status of Indonesian people. Thank you for your dedication toward this transformation journey. May we forge a brighter and a higher future for the global community. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much to Dr. Arianti Anaya MKM for joining us on this conference. It's very, very honor for us, Doctor, for having you here participating in this conference. And I want to ask your permission. There are hundreds of our nursing students here. Want to greeting you
Wonderful.
on the Zoom
Wonderful.
meeting. So please help the committee showing the students.
Thank you.
Yeah, here.
Appreciate to Poltekkes Gorontalo and Pak
Yes.
Direktur.
Yes, you're welcome. We're very, very welcome, Dr. Arianti Anaya. Thanks again for your willingness for joining with us. Thank you very
Thank
much,
you.
Doctor.
Yeah, thank you.
Yes. All right, ladies and gentlemen, now we're moving to the next agenda that maybe have been waiting for all of the participants. So please stay on the Zoom meeting. We will announce for the best participant of the seminar. And for the announcement, I will give it back to our Master of Ceremony today. So to the Master of Ceremony, I give it over to you.
Thank you, Mrs. Fahriatul Fala, and thank you for the Dr. Gigi Arianti Anaya MKM for the speech. Ladies and gentlemen, we will announce the best participants for the today's sessions. These persons will be rewarded a 50,000 funds credit voucher from our sponsor. And our best participants today goes to Ira Miriani, escape nurse from Universitas Indonesia. Congratulations. The committee will contact you soon.
Yeah, congratulations to Mrs. Irmariani Irban. She also one of our lecturer before in Poltekkes Gorontalo and now earn her Master of Nursing in University of Indonesia. Congratulations, Mrs. Irma.
Ladies and gentlemen, that concludes our first day of the International Conference on Nursing's Update in Healthcare 2023. We will see you again for the plenary tomorrow starting at 8 a.m. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Yeah, for information for all participants, we inform you that tomorrow the plenary speaker active will start 1 p.m. for Central Indonesian time, and for oral presenter, please be prepared because the presenter oral active will start at